IPDMS 2.0 Integrated Pharmaceuticals Database Management System version 2 upgrades the current IPDMS with latest technological interface. IPDMS 2.0 is an integrated responsive web-based application for manufacturers, importers, application for manufacturers, importers, marketers, distributors, consumers, price monitoring resource units, PMRUs. In the pharmaceutical, facilitate the stakeholders to connect with nationals. A change that will ensure a more efficient, transparent and time-bound online functioning. A change that will optimize synergies in operations to promote government's thrust on ease of doing business, as it would provide a single window for submissions of various forms as mandated under DPCO 2013. A change that will facilitate the stakeholders to connect with National Pharma Pricing Regulator, as multi-instance architecture of IPDMS 2.0 has the capability to connect multiple users over a public network infrastructure. A change that will facilitate consumers to access information on pricing and availability of vital medicines. A change that is part of making India digital.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. A very good afternoon to all. On behalf of Price Monitoring Resource Unit, Karnataka and Drugs Control Department, Karnataka, we extend a very warm welcome with great joy and immense exultation to all the dignitaries and subject experts from National Pharmaceutical Pricing Authority, USFDA, pharmaceutical industry, medical professionals, health professionals, NGOs to this seminar. We heartily welcome all the stakeholders and participants who are attending today's session offline and online throughout the country. I am Dr. Bhaskaran, Deputy Drugs Controller, Drug Control Department, Karnataka. The theme of today's seminar is Health and Wellness, Fixation of Ceiling Price under National List of Essential Medicines, NLEM 2022, Ensuring Affordability. To speak on the topics of the said subject, which are lined up for the day, we have with us subject experts around the globe with great profile and vast experience who will enlighten us with their immense knowledge. I really promise you that today's session, technical session, will create a great learning experience for all of us. We have with us today for the technical session, we have with us Shri Bhagavati Anapure, Drugs Controller for the state of Karnataka, and the Chairman of the Executive Committee, PMRU Karnataka. Sir, I request you to kindly take the seat on the dais. Please put your hands together. The chief guest of today's program is Shri Sanjay Kumar, sir, Advisor, NPPA, Department of Pharmaceuticals, Government of India. Sir, I request you to kindly take the seat on the dais. Dr. Amrish Tumagi, Additional Drugs Controller and Member Secretary, Executive Committee, PMRU Karnataka. Sir, I request you to take the seat on the dais. I request Shri Mohan, Principal Scientific Officer, Drug Testing Laboratory, to take the seat on the dais. We have Dr. Suresh Shastri, State Program Officer, Ayushman Bharat Arogya, Karnataka Scheme. He will be joining us shortly. We welcome you, sir. We have Shri Sunil Athavar, Managing Committee Member, Karnataka State Drugs and Pharmaceutical Manufacturer Association. Sir, I request you to kindly take the seat on the dais. Our next dignitary is Shri Somshekhar, VK Managing Trustee, Graha Shakti. He will be joining us shortly. I request Dr. S. Umesh, Deputy Drugs Controller, Bangalore, to take the seat on the dais. I request Dr. Sunil Chiplankar, Vice President, Business Development, Group Pharmaceuticals Limited, to kindly take the seat on the dais. Today, to the technical session today's program, we have Dr. G. Jagadish, former scientist, former senior expert, Center for Drug Evaluation and Research, USFDA, Maryland, USA. He is on a virtual mode from USA. We welcome you, sir. Dr. Preeti John, Deputy Director, MBA Health, Global Business School for Health University College, London. She is on the virtual mode from London. We welcome you, madam. Before we start the program, any good thing, we first pray to the God, right? To attain some strength and inner peace. I request Srimati Vallari, Scientific Officer, Drug Testing Laboratory, to present the invocation song.
ಗಣಪತಿಯನ್ನ ಪಾಲಿಸೋ ಗಂಭೀರ ಗಣಪತಿಯನ್ನ ಪಾಲಿಸೋ ಗಂಭೀರ ಪಾರ್ವತಿ ನಂದನ ಸುಂದರ ವದನ ಪಾರ್ವತಿ ನಂದನ ಸುಂದರ ವದನ ಸರ್ವಾಧಿಸುರ ಪ್ರಿಯ ಶಿರವಾಗುವೆನ ಗಣಪತಿಯನ್ನ ಪಾಲಿಸೋ ಗಂಭೀರ ಆದಿಪೂಜಿತ ನೀನು ಮೋದ ಭಕ್ತರಿಗಿತ್ತು ಆದಿಪೂಜಿತ ನೀನು ಮೋದ ಭಕ್ತರಿಗಿಟ್ಟು ಮಾಧವನಲ್ಲಿ ಮನಸದ ನಿಲ್ಲಿಸು ನೀ ಆದಿಪೂಜಿತ ನೀನು ಮೋದ ಭಕ್ತರಿಗಿಟ್ಟು ಮಾಧವನಲ್ಲಿ ಮನಸದ ನಿಲ್ಲಿಸು ನೀ ಗಣಪತಿಯನ್ನ ಪಾಲಿಸೋ ಗಂಭೀರ ಪಂಕಜನಯನ ಶ್ರೀ ವೆಂಕಟ ವಿಠಲನ ಪಂಕಜನಯನ ಶ್ರೀ ವೆಂಕಟ ವಿಠಲನ ಕಿಂಕರನೆನಿಸೆನ್ನ ಶಂಕರ ತನಯನೆ ಪಂಕಜನಯನ ಶ್ರೀ ವೆಂಕಟ ವಿಠಲನ ಕಿಂಕರನೆನಿಸೆನ್ನ ಶಂಕರ ತನಯನೆ ಗಣಪತಿಯನ್ನ ಪಾಲಿಸೋ ಗಂಭೀರ ಪಾರ್ವತಿ ನಂದನ ಸುಂದರ ವದನ ಸರ್ವಾಧಿಸುರ ಪ್ರಿಯ ಶಿರವಾಗುವೆನ ಗಣಪತಿಯನ್ನ ಪಾಲಿಸೋ ಎನ್ನ ಪಾಲಿಸೋ ಎನ್ನ ಪಾಲಿಸೋ ಗಂಭೀರ.
Thank you, Srimati Vallari, for a beautiful invocation song, prayer song. Lighting a lamp before a ceremony spreads divine grace. The lamp also shows everyone who is present how to raise upwards and dispel darkness. By lighting a lamp, the lamp becomes a fire, form of a fire or tej in Sanskrit. The lamp burns, not to be the light itself, but merely a message to remind all who are present of peace and of positive brightness. Now I request the dignitaries on the dais to please illuminate the session by the process of lighting the lamp. Thank you all. Srimati Nagajoti, Assistant Drugs Controller, to present a floral bouquet to Srimati Valerie. Miller. And the certificate of appreciation. One way to better understand your own health or health of your loved ones and help you to reach your health and wellness goals. PMRU is to assist NPPA in monitoring the prices of drugs, ensuring availability of the drugs, and raising consumer awareness. This is just an abstract of today's technical session, and we're going to have a big deliberations from the speakers. I request Dr. Amrish Tumbigi sir, Additional Drugs Controller and Member Secretary Executive Committee PMRU, Karnataka, for the welcome address and the introductory remarks.
Thank you, Mr. Dr. Bhaskar. Ellorigu namaskara. A very good afternoon to all dignitaries on the dais, off the dais, dignitaries who are joined through via YouTube, the links, all dignitaries, invitees. It's a matter of proud that health sector has changed a lot in 2 decades. So when you see what we were 2 decades back, now it has come bigger way. So please come. Come.
I request Sri Somsekhar, VK Managing Trustee, to please come on to the dais. We welcome you, sir.
Health sector requires a lot of collective efforts. It is a compromising from doctors, pharmacists, nurses, paramedics, all those people makes a bigger way for change of health activities. So with this, today we have a theme of health and wellness, fixing of price of NLEM 2022, of ensuring affordability. So this theme today, health and wellness, and fixation of price of NLEM 2022, ensuring availability, is the need of the day, because we have seen cost of the healthcare, how it is increasing, how it has to be reduced, is to be addressed today. So this is a big theme. We have a big technical sessions. For this seminar, I wholeheartedly welcome our beloved, respected drugs controller, Dr. T.K. I request B. Ramesh to present a flower bouquet as a token of love. On behalf of Government of Karnataka, Drugs Control Department, Karnataka Price Monitoring and Resources Unit, and personally, I wholeheartedly welcome Dr. Sanjay Kumar, Advisor, NPPA, Department of Pharmaceutical, Ministry of Chemical and Fertilizers, Government of India, to this historic sessions. And I request Sri T.K. sir to present a bouquet to the token of love. I wholeheartedly welcome Dr. S. Mohan, Principal Scientific Officer, Drug Testing Laboratories, Bangalore, to this historic seminar. I request Dr. Rajendra JSO to present a bouquet to this Mohan sir. today's speaker, Dr. Suresh Shastri, is on the way. I welcome in his absence. I also welcome respected Dr. Preeti John, Deputy Director, MBA, Chair Board of Examiners, Global Business School for Health, University College London, to this seminar virtually, who will be joining, who has joined already in the seminar. I also warmly welcome respected Dr. G. Jagdish, former senior expert, CDRE, USA, who will be joining on the virtually. I welcome Dr. Sri Sunil Atawar, Managing Committee Member, Karnataka Drugs and Pharmaceutical Manufacturers Association. I request Sri Ganesh Babu to present a flower bouquet as a token of love. I welcome from bottom of my heart our beloved consumer activist and consumer man who works for consumers, Krak Shakti, Dr. Somsekhar VK, Managing Trustee, Krak Shakti, to this seminar. I request Kumari Shahina to present a flower. I welcome Dr. Sunil Chiplavkar, Vice President, Business Development Officers, Group Pharmaceuticals, who will be conducting a big pitch in these activities. I request Sri Bhaskar to present a flower bouquet to you. I also welcome my colleague Dr. S. Sumesh to this seminar. I request Sri Sadanand to present a flower bouquet. I heartily welcome President of Karnataka Drugs and Pharmaceutical Manufacturers Association President Dr. Harish Jain ji for this seminar. I request M.A. Suresh to present a bouquet to you. We have our former colleague Sri H. Srinivasa. I request Sri Ajara Shah to present a bouquet to H. Srinivasa. I welcome him, sir. I sincerely welcome respected Karnataka Principals Association President, Vice President, members of the association, principals of all pharmacy colleges of the states who are joined via YouTube and Zoom, and some of them have come here. Also welcome from bottom of my heart, President, Vice President, members of various chemist and druggist association of Karnataka for joining via YouTube and having present here also. Also welcome President of Karnataka State Pharmacy Council, who is supposed to join. He will be joining also. On his absence, I will cover it up also. I welcome my colleagues. So Dr. Kembaya Suresh, P. Ramesh, Bhaskar, then Mallikarjun Nagu, Ajay Shah, Ganesh Babu, Bhagya Jyoti, Chandrakala Silpa, then we have all my, on behalf of all of department and PMRU, I welcome all my colleagues. Also welcome all invitees who have been gathered here and who are joined via YouTube also. I humbly wholeheartedly welcome all dignitaries who have joined. So through other medias also on this a beautiful seminar which is likely to give an inside thought of Government of India, Government of Karnataka made efforts to bring down the cost of the drug, how healthcare system has been brought down after pandemic activities. I take this liberty. I wanted to express a few words, the purpose of this seminar and how Government of India and Government of Karnataka has made affordable activities. The definition of health is very big. As per WHO is concerned, it is a state of complete physical, mental, social well-being, not only free from disease or illness. That means health is, you have to be, one has to become healthy means you should be a state of complete physical, mental, social behavior and not free from disease and illness. This is a wellness activities. If you consider wellness is the proactive lifestyle of the human beings. So in one word, one sentence, if you wanted to say today's theme, health and wellness, health is the goal of human beings, wealth is the process of reaching the goal. So these health and wellness make today's topic given by the central government to organize this is a well thought and is a today's need of these things. The healthcare industries has changed a lot. It has, during pandemic to this level, we have made a lot of changes in our implementations for the access of care, for proactive care, for quality care, for cost of the care. Even though we have achieved several goals in assessing care, quality care, cost care, everything, we have not completely achieved a free of healthcare activities. So in this, then we have a certain criteria where we could not identify certain issues still pending. That I feel all our technical speakers will cover it up. Basically, if you see the cost of treatment, it varies from person to person, hospital to hospitals. ನಾನು ಒಂದೇ ಹೇಳ್ಬೇಕಂತಂತಂದ್ರೆ ಈಗ ಒಬ್ಬರಿಗೆ ಕ್ಯಾನ್ಸರ್ ಅಂತ ಏನಾದರೂ ಬಂದುಬಿಟ್ರೆ ಮನೆಯಲ್ಲಿ ಒಬ್ಬರಿಗೆ ಕ್ಯಾನ್ಸರ್ ಬಂದರೆ ಎಂಟೈರ್ ಫ್ಯಾಮಿಲಿ ಹ್ಯಾಸ್ ಟು ಟೇಕ್ ಕೇರ್ ಆಫ್ ಇಟ್. ಇಟ್ ಹ್ಯಾಸ್ ಬಿಕಮ್ ಅನದರ್ ಆಕ್ಟಿವಿಟೀಸ್, ಎಂಟೈರ್ ಫ್ಯಾಮಿಲಿ ಬಿಹೇವಿಯರ್ ರೆಸ್ಪೆಕ್ಟ್ಲೇ ಚೇಂಜ್ ಆಗುತ್ತೆ. ಒನ್ ಸೈಡ್ ಬರ್ಡನ್ ಆಫ್ ದ ಟ್ರೀಟ್ಮೆಂಟ್, ಅನದರ್ ಸೈಡ್ engagement of the people. So I feel we need to cut short certain cost of the healthcare where we have to think on it. Our speakers will speak on it. So second question arises whether all citizens receive equal healthcare. People who have got money, they will go to the big hospital. People who have got who are not in a position, they may not go there. ಈಗ ಬಡವರಿಗೆ ಮತ್ತು ಶ್ರೀಮಂತರಿಗೆ ಒಂದೇ ಥರ ಈಕ್ವಲ್ ಆಗಿ ಮಾಡೋದಕ್ಕೆ ದೇರ್ ಮಸ್ಟ್ ಬಿ ಸಿಸ್ಟಮ್ ಇನ್ ಪ್ಲೇಸಿಗೆ ವಿ ನೀಡ್ ಟು ಡೂ ಆನ್ ಇಟ್. ಸೊ ಈ ನಿಟ್ಟಿನಲ್ಲಿ ಸರ್ ಈ ಇವತ್ತಿನ ಟೆಕ್ನಿಕಲ್ ಸೆಷನ್ ಹೆಲ್ತ್ ಆ್ಯಂಡ್ ವೆಲ್ನೆಸ್ನಲ್ಲಿ ಕವರ್ ಮಾಡುತ್ತಂತ ನನಗೆ ಒಂದು ಭಾವನೆ ಇದೆ. ಸೊ ವಿ ಆಲ್ಸೋ ಹ್ಯಾವ್ ಎ ಪ್ರಾಮಿಸ್ ಆ್ಯಂಡ್ pitfalls in the technologies because today's healthcare entire system depends on the diagnostic activities. We have seen false positive, false negative and pitfalls also. We also see certain criteria where people says unnecessary testing have been done, unnecessarily made the patient to stay in the hospitals. These are all some allegations are there. Those are things how to cover it up also. This seminar technical session will address them. We also have a value-based care to be done because people who have, as far as constitution is concerned, health is a fundamental right for all of us. Everybody has to get these things. We need to have a bigger thought on that. We also this is one side we need to give all people, citizens, equal cadre of equal status of health activities. At the same time, we also have a shortage of professionals. If you wanted to go to the hospital, rural area, there is a shortage of doctors, there is a shortage of nurses, we are also addressing all those things. Our today's activity is how India, Karnataka will address it. At the same time, we also requested foreign international speakers to cover it up, how low-income countries of the globe, middle-income countries of the globe, how high-income countries of the globes are addressing these health issues and health wellnesses. So these are all things will be covered. Considering certain issues, government, WHO during 2012, December 12, even passed on resolutions that is called Universal Health UHC. So every December 12th we celebrate it, 12th December as Universal Healthcare these things. So that universal healthcare requires any persons, anywhere, when they go, whether they are staying in their native place, whether they go out of station, all persons should get an access to the health of, from promotion to diseases. They need to treat, they need to give them a treatment, rehabilitation, palliative care, all those things has to be done. Not only where their address is there or they are not there. All global activity is done. Today we have a G20 presidency where one earth, one family is the concept. Sir, Suresh sir, please come. I welcome Dr. Suresh Shastri sir. I request Sri Mallikarjuna to present a welcome. Dr. Suresh Shastri sir is the master of Universal Healthcare program. He will give you a total thought how the government of India made, instead of insurance policy, government has came out Ayushman Bharat Arogya Karnataka, how we have made it as assurance activity, not only insurance activity, we made it as an assurance activity by Karnataka. That is a big thought we have done it in 2018 when it has been implemented. So this Ayushman Bharat basically has got two segments. One is health and wellness, another one is Pradhan Mantri Jan Arogya Yojana, where we give an insurance whoever will go to the hospital, who are in the backward, financially backward activities. This activities will be covering by our Dr. Suresh Shastri, who is a master in there. So if it comes to the fixation of NLEM 2020, we need to think on it. I will not take more than 2-3 minutes. So we have essential drug, we have affordable drug, we have affordability, we have an availability, we have a quality drug also. All these things will be taken during our technical sessions. With the short of time, I wanted to close this thing. Overall, today's program will continue with a theme that we will be addressing health and wellness, especially cost of treatment, inequality in the treatment, proof and pitfalls of technology, value-based treatment, shortage of health professionals, basis of considering products, and national health essential list of medicines, the factors considered while determining the selling prices, manufacturer efforts in making affordable medicines, consumer rule in affordable medicines. This seminar will enlighten on overall theme of this thing, health and wellness of the Karnataka, India, low-income countries, middle-income countries, and high-income countries. Overall, this 75th Azadi Ka Amrit Mahotsav, along with inclusion of 20 presidents, will be addressed in these activities with respect to health and wellness and price fixation of prices. With this, I remember when I was a student, it was treated as it used to be said as health is wealth. Now it has changed. Good health is above wealth. I wish all of you have good health. Thank you. Thanks a lot. Jai Hind, Jai Hind.
Thank you, sir, for your humble welcome note. I request Sri Baguji T. Kanapore, Drugs Controller, to welcome Dr. Amrish Tumge, sir, by presenting him a floral bouquet. Now, I request our chief guest of today's program, Sri Sanjay Kumar, Advisor, NPPA, Department of Pharmaceuticals, Government of India, to address this august gathering. Karnataka, and he is also the executive director of the committee of our PMRU Karnataka. Dr. Suresh Sastri ji, the State Program Officer of Ayushman Bharat Karnataka scheme. And I will also like to welcome Sri Professor Jagdish, who has joined virtually from the US, and Dr. Preeti John, the Deputy Health University College, the dignitaries on the dais, and all the participants who are present in this auditorium. You must be very proud that we are just a few days ahead of our Independence Day, on which this Azadi Ka Amrit Mahotsav is likely to culminate. This is my pleasure to be here in this program, and particularly with this theme, that is the health and wellness. Health and wellness is a theme which concerns everybody. Let it be a child, let it be a old citizen, it concerns everybody. So, as Dr. Amrish said, we will try to address this. And then the other aspect is that is how the fixation of ceiling prices makes the drugs affordable for everybody. I'll be addressing those issues in my I have a technical session, so I'll be detailing on the fixation of the ceiling prices. As you may be aware, National Pharmaceutical Pricing Authority, or as we say in the brief, NPPA, was established by the Government of India by a resolution on 29th August 1997 as a regulator body for the pharmaceutical industry. This is a body of the experts, and the prime responsibility of the NPPA is the fixation of the prices. NPPA not only fixes the price of the ceiling price, not only fixes the ceiling price of the scheduled drug, we also fix the price for the some of the non-scheduled drugs, which we normally call as a new drug. So, I will try to cover this in my presentation, and then how it's not only the fixing in such a way that it becomes affordable for the consumers, and most importantly, it's also available with the consumers. So if the prices are fixed and if it is not reaching to the consumer at that price, then it will not yield the desired result. So the NPPA's mandate is also to ensure that it's available throughout the country, in all corners of the country. When we talk about the monitoring of this, monitoring of the prices, correct prices of the drugs available in the market, and the availability thereof in all corners of the country, then the monitoring becomes one of the major activity. Because unless until somebody monitors, it will not be able to it will not be possible to ensure that it's available at the correct price, and most importantly, it's available throughout the corners of the country. Let me share with you that, because that is one of the themes of our today, that fixation of the ceiling prices under NLEM 22. So only the ceiling prices, so far we have fixed ceiling price of 691 drugs under the NLEM 2022, and the total saving which we estimate, that is the price reduction on account of the revision in the ceiling prices, that works out to rupees 3,550 crore annually. So this is a great help for the consumers when we talk about the pricing. Beyond this, we also monitor that whatever the non-scheduled drugs are available. I hope everybody will be clear about the scheduled drugs and non-scheduled drugs. Otherwise, when we go into the technical session, I will elaborate on that. We also monitor that the prices of the non-scheduled drugs are not increased beyond 10% annually. So they have the maximum cap because they have also their increase in the expenditures and all these things. So we also ensure that. So when we are talking about the monitoring, as the NPPA is headquartered in New Delhi, so to increase the outreach of the NPPA is implementing a central sector scheme titled as Consumer Awareness, Publicity and Price Monitoring, which is a central sector scheme. The objective of this scheme is to create general awareness about the availability of the medicines, prices of the medicines, ceiling prices of the medicines fixed by the Government of India, and most importantly, the precautions to be taken by a consumer while purchasing the medicine. So that is also one of the job which our PMRUs are doing by way of the dissemination of the information on this. The PMRUs are set up in all the states and all the UTs under the direct supervision of the State Drug Administration, and at the central level, the scheme is monitored and implemented by the NPPA, and it's executed by the PMRUs. So far, you'll be happy to know, out of the 36 states and UTs, we have already established PMRUs in the 29 states or UTs. So, and in the remaining also, I think during this year, we'll be able to go with the remaining states and the UTs which are left over. Now talking about the Karnataka PMRU, because of whom we have all been here today. So this was established way back in August 2020, and this was 13th PMRU in our registration. So this was the 13th PMRU in the registrations. PMRUs are across the country. They are keep organizing this kind of the programs, awareness program, to make the consumers aware about the availability of the drugs and at affordable price. PMRUs are working in the states and UTs, have made commendable contribution in ensuring the drugs required for the COVID management. As you are aware that we passed through a very difficult phase when the entire country was put under the lockdown, but the health system was still working. So not all the health workers, all the health departments of the government of states, UTs and the at center were working very hard. So in those cases, the PMRUs are conducting the surveys. They will conduct regular surveys with the hospitals, with the pharmacies, the stores, and a report will be sent to the NPPA that these are the drugs which are required and are available or are not available or are available in a very short quantity. And then based on these only, the NPPA was able to manage the rationalization of the quantity so that it is available in all the corners of the country. So the work done by the PMRUs during that COVID phase is really commendable. It must be appreciated by everybody. I think I will not take too much of the time, but before that I must compliment the officers of the Drug Controller Department of the Karnataka, especially Dr. Babuji Khanpure Sahab, for giving his leadership for organizing this program. This as Dr. Amresh has already told, this is going to be a very relevant program for all the participants who have joined us. I hope that the takeaways, you will definitely have some takeaways from here, today's deliberations. So this will make your pharma knowledge
at least the knowledge you are required to have as a consumer of the pharmaceutical products will be increased and it will be quite useful. So I again thank you all the participants for joining us. Thanks a lot.
Thank you, sir, for your brief note. I request Sri DCD-KARNATAKA, sir, Drugs Controller for the State of Karnataka, to present a memento to Sri Sanjay Kumar, Advisor, NPPA, Government of India. PMRU Karnataka has created a segment in the department website drugs.karnataka.gov.in, and this is the first of its kind in the entire country. I request Sri DCD-KARNATAKA, sir, Drugs Controller for the State of Karnataka and the Chairman of the Executive Body PMRU Karnataka, to launch the PMRU segment in the website of the Drugs Control Department Karnataka.
is Chairman of Governing Body of NPPA, and Dr. Amresh Tungi, Additional Drug Controller, and Dr. Suresh Shastri, Sri Somshekhar and Sunil Adhawarji, Sri S. Mohan, and of the online they are present now, Sri Jagdish and Mr. John also, and learned speakers also present over here now. And sorry, Dr. Suresh Shastri, I told. And learned speakers from the department, delegates of pharma field, wholesale and retail businesses from Bangalore who joined here now. Participants from the industries, healthcare professionals, students and the other esteemed members of this presented audience. We have joined this seminar on virtually also from all over Karnataka also. It is indeed a great moment and joy for honor for me to present my presidential speech today. I am happy to launch the website just now segment on Price Monitoring and Resource Unit Society PMRU, which aims to have hands-on information on all the activities conducted by PMRU Karnataka. Congratulations to everybody now. I would like to recognize the presence of Sri Sanjay Kumarji, Advisor, NPPA Department of Pharmaceuticals, Government of India, New Delhi, who is a kind enough to join us as the chief guest for this inauguration. And also, though focus on fixation of ceiling prices under NLEM 2022 you have seen, sir. Ensuring the affordability, and he will deliver the talk after some time. I extend my thanks to you coming over here from Delhi to Bangalore. Thank you, sir, once again. Ladies and gentlemen, Karnataka Price Monitoring Unit Society has been set up under the Society Act on 12/8/2020 as Dr. Amresh Tungi has said, under the aegis of NPPA, Department of Pharmaceuticals and Chemicals and Fertilizers now, the Government of India. It is great honor for me as the 13th state of PMRU is set up in Karnataka. I am grateful to NPPA all chairman and other persons giving this opportunity to Karnataka to serve the people of Karnataka. And also myself, being a chairman of Executive Committee, PMRU Karnataka, and today we have conducted 8 outreach programs throughout Karnataka to create the awareness about the initiatives taken by the central and state government for the availability of affordability of quality drugs in the country to serve the people of citizens. And more than 600 beneficiaries have attended these seminars, outreach programs, and got benefited now, the entire Karnataka. This has created awareness about the ceiling price drugs fixed by NPPA in respect of 890 scheduled drug formulations and retail price fixed under for 2023 for non-scheduled drugs done during 2013 to 2022, sir. In today's era, information technology is also one of the major criteria we should took into the technology to ensure affordable and availability of quality medicines for all. Our information, education and communication activities also created awareness about the digital platform provided by the NPPA, like one pharma sign down mobile app for the consumer to know the right prices of the medicine. Second, Price Jan Samadhan on e-portal for lodging public grievances in respect of excess price. and about non-availability of drugs and refusal of sale medicines also. As aware of that, we have taken lot of cases also now. We are informed to NPPA now what are the prices, excess prices already we initiated, we detected in the Karnataka now. And integrated the pharmaceutical database management system also we adopted to responsive web-based application for manufacturers, importers and marketers and distributors and consumers through PMRU in pharmaceutical and medical devices sector also now. We have covered different districts. Rightly says that Karnataka, namely Mysore, Bangalore, Belgaum, Dharwad, and other we are going to other districts also now in past times. IC activities will be conducted throughout state to give the information to manufacturers and government for what the policies are in the NPPA through these activities now. And Karnataka PMRU has gone all over the awareness activity in providing consumer benefits provided to the DPCO 2013 and opportunities, schemes and policies, supports provided by the government of pharma industry. And we respect the price monitoring PMRU and also trace the suspected ceiling price violations and 4 drugs and matters under verification, sir. And we are going to send a report to you, sir. And Karnataka PMRU is also assisted in the due recovery process also, sir. Excess pricing done by the pharma industries and many such activities. Recently, one of my colleagues is given now fixation violations is there, sir. And I will take it as positively. I'm going to see that what ceiling prices differentiation is there in MRP. Definitely we are going to take that and we will inform to you, sir. And ladies and gentlemen, today
IPDMS 2.0 Integrated Pharmaceuticals Database Management System version 2 upgrades the current IPDMS with latest technological interface. IPDMS 2.0 is an integrated responsive web-based application for manufacturers, importers, marketers, distributors, consumers, price monitoring resource units, PMRUs, in the pharmaceutical and medical devices sector. An online system for the pharmaceutical as well as the medical device industry that will facilitate the stakeholders to connect with National Pharma Pricing Regulator from across the country without the need of visiting the office. A change that will ensure a more efficient, transparent and time-bound online functioning. A change that will optimize synergies in operations to promote government's thrust on ease of doing business, as it would provide a single window for submissions of various forms as mandated under DPCO 2013. A change that will facilitate
so many status now online. Dr. Preeti John, Deputy Director MBA and Global Business School of London, will join us virtually from London. I am not going to take much of time now. It is already time now. Thank you very much for inviting all of you to stand together to success this 9th PMRU function today now. Thank you one and all. Thank you very much.
Thank you, sir. I request the Chiefest, Sri Sanjay Kumar, sir, Advisor, NPPA, Department of Pharmaceuticals, Government of India, to present a memento to Sri Bhagojiti Kanapure, sir. I request the other dignitaries to please join. request the Chief Guest, Shri Sanjay Kumar, Advisor, NPPA, to present a memento to Dr. Amarish Tumbagi, Sir, Additional Tax Controller, Member Secretary, Karnataka. I request the dignitaries to please join.
As the result of government
So we have come to the end of the inaugural session. I request the dignitaries to please kindly occupy the seats below for the next important technical session of the day. I'll answer. Let's begin the technical session. Are you ready? Fresh after having a cup of coffee? Good, good, good. Let's start the important technical session. The term health and wellness are often used interchangeably. However, there is a subtle degree of difference between the two. Well-being can be considered to be the precursor of health. It's an active process involved in making choices for a healthy and fulfilling life. Well-being is achieved through a dynamic lifestyle which encompasses various aspects including self-reliance, physical fitness, nutritional awareness, stress management, and environmental sensitivity. It is a feeling experienced by a person about their health and quality.
and can also search alternative medicine by tapping the Search Medicine Price tab. This app also provides speech recognition facility. With the help of Share button in this app, consumer can easily share the information about medicines and their prices with any person. Complaints about the higher price of medicine can also be done through this app. To file a complaint, click on Register Complaint in the Complaint Management System of the app. Then choose the nature of complaint such as overpricing, non-availability or shortage of drugs, sale without price approval, refusal of supply or sale. An OTP will be sent to your mobile for verification and your complaint will be registered. In this section, you can also check the status of your previous complaints besides the details of redressal. Therefore, install Pharma Sahida mobile app in your mobile. Pharma Sahida mobile app, power of every consumer.
He has also managed important programs like HIV treatment and TB at the state level. He has also published more than 50 articles in the national and international journals. Maybe I should cut short, maybe otherwise it's a big thing. Let's hear it from Dr. Suresh on health and wellness Indian scenario.
ಬರೋ ತನಕ ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಸೊ is first time I regularly come here, but this is the first time I came here for a talk. Otherwise, both of them are my good friends, part 1 and 2. They're my very old friends for more than a decade now. But this topic is a very broad topic. Health and wellness, anything under sun it comes under this topic actually. So COVID has taught us many good things, and one of the important things is physical and mental well-being. So COVID actually drained everybody, and we lost so many of our friends, colleagues, family members. But after COVID, post-COVID, you started thinking about many good things.
like well-being, wellness, health. Now people have gone to, at the national level there is a thinking that health and wellness should go hand in hand. All these days we are only talking about health. Now there is so much of importance for wellness, well-being, and a lot of focus on alternative system of medicine, yoga. All those things are coming together. Otherwise it's all vertical. So all those things are coming together, and that should make the country very healthy. And that next generation should, the quality of life should improve in next generation. They should eat well, they should think well, and their body and mind, soul, everything should be pakka, and they can lead our country for next 50 to 100 years. That's how it is. So I'll be just touching the important aspects with a special focus on the insurance and assurance models on health, how it works, what is the present scenario. I have to forgive me because I don't have laptop, so I'll be seeing here and there is not much written there. It's more of talk. Okay. First slide, please. So broadly, we are looking at these things: cost of healthcare, cost of health, then equity in healthcare, then technology in healthcare. It's a very big thing now. Now data and all those things are the new gold, new oil. Now everything is data, everything is technology. So value-based care, we are treating quantity, but should focus on also quality and value-based care. We should focus on those things. Then supply and demand gap. In healthcare, basically healthcare, I'm focusing on that. Is there sufficient output, sufficient number of doctors or healthcare staff available? Whether there is a gap, whether there is very high attrition, all those people have to deliberate. Hello? Yeah. So we are on the cusp of change. On one hand, there is urbanization, there is tremendous economic growth, everything is moving in a fast pace. On the other hand, it is taking toll on our health. And there are pockets which are becoming rich or stable, and there are some pockets still which need a lot of attention. So it is not same, it is changing, everything is disparity. In Karnataka, northern part is different, southern part is different. The health indicators are different, the focus is different, the religious beliefs are different, the culture is different, everything is different. So it's a challenge. It's a very complex thing to bring everything together. Okay. Then medical field is advancing. You all know that, all of your seniors also. The way the things are moving so fast, now everything is robotic, everything is nanotechnology, everything is AI based. Even your drugs are given as nano drugs now. Previously over the counters you used to tell, oh, this, take this. Now it has gone to that level. The things are changing. Okay? ಅವ್ರು ನನ್ನ ಮುಖ ಏನು ನೋಡೋದು ಬೇಕಾಗಿಲ್ಲ, ನೀವು ಸ್ಲೈಡ್ ತೋರಿಸಿ ಸಾಕು. ಅವ್ರಿಗೆ ಸಾಕಾಗಿದೆ ಆಗಲೇ ನನ್ನ ಮುಖ ನೋಡಿ. So go back. So we have to balance it. There are people who can afford, who can go for advanced things, but there are not so fortunate fellows. We need to provide them low cost treatment, quality treatment. In your, I think in pharmacy you have chemists here, you have big shops here. On the other hand, we have Janaushadhi. So we have to balance. Okay. Then in India there is a peculiar situation. On one hand we are advancing in allopathy. On the other hand there is Ayurveda, and there are alternative systems of medicine. So we have to balance between all three. Then only you will get into health and wellness. Okay. Then investment and socialistic issues. Investment. The country is moving fast. There is a lot of economic development. The GDP is improving. The per capita is increasing. But there are pockets who are very poor. They also deserve equal treatment. They also need health and wellness. Not just the only so-called creamy layer. So again we have to balance. So that is a socialistic angle which comes into play. Okay? Then disease patterns. The disease patterns are changing. You have not seen your parents and grandparents having diabetes, hypertension at the age of 35, 40. They were very healthy. Even now they will be more healthy than you because lifestyles have changed. So it's basically about the environment, the eating pattern, stress, your genetic makeup, all those things come into play. So lifestyle changes leading to more diseases, leading to more types of problems. That is seen in the places where there is economic development, where there is quality of life has improved. So you'll see non-communicabilities more. You go to, recently you must have seen in Chitradurga or in Raichur, still you get cholera, still get infectious diseases. So there are pockets which are very poor, there are pockets which are not so poor. Again we have to balance. Okay? All these things actually shape the healthcare. Everything is required, everything we should balance. So all these things actually matter. So this is how the pattern has changed. Just it's a very simple, right? 1990, you see, all the communicable diseases, maternal, neonatal, nutritional issues, marasmus, malnutrition, they were making the majority, 60% of them. Gradually 2016, boom. So it is more of non-communicable disease. I think you must have seen the people coming were 10 or 15, maybe 10 years back, for collecting diabetic hypertension. Now already 100 fellows will come. So that's how the shift has taken place. The NCD and India will be diabetic capital by 2035, will be the world capital. We have 1.4 million population. Now almost 36% population has moved to urban areas. From rural areas, people have come to urban areas. There are lucrative offers in urban areas, but there are side effects also. Both. So you will see more and more incidents. And on the Indian map, it highlights, look at the southern states, quite well off, developed. The per capita income is better, the infrastructure is better, the quality of life is better. So we'll see more of NCDs. Look at those states in the middle part. Still infectious diseases are high there. So now they are also on development path. You must have seen a lot of good things coming from northern India also. Gradually in the next decade they will also move. They will also become blue. So India has huge challenge. Next one. The scenario is, it's not so rosy. Okay. So we have to think on multiple angles here. 52% of the finances to health is through out-of-pocket expenditure. That means still people are paying from their pocket, from their hard-earned living. That means there is a scope to cover this population under insurance or assurance schemes to prevent this out-of-pocket expenditure. That is vital. I'll come to that when I talk about Ayushman. Then large dependence on private sector. You have nice government sector. Gradually things are improving, but still majority people go to private sector. And it is not uniform across the country. In southern part, the health infrastructure is much better than some of the northern states. Gradually they will also pick up. So government is there, but still people rely on private sector. Because there are advantages like the quality of care, the infrastructure, the way, the empathy, the way they treat the patients as a beneficiary or customer. All those things matter. In government, we need to improve our interpersonal communication skills. That is the first thing. So I just touched upon that. Okay. So then, see, inpatient services and prescribed medicines contribute to 43% of the costs. Out of that 43, 20% is going for medicines. 20% is going for medicines. So it's a huge cost. If somebody is earning and he is spending this much money, he has to borrow or he has to sell something. It's not an easy job. That's why health is wealth. That's what Tungi sir was telling now. Now health is the only wealth. Okay, gradually as you move on, health is the only ಸಾಕಪ್ಪ ನೆಟ್ಟಿಗಿದ್ರೆ ಆ ಸ್ಟೇಜ್ ಬರ್ತೀವಿ. causes demographic transition, rapid urbanization, rapid industrialization. You've seen 36% moving to urban areas. So I also moved from village to Bangalore. So you also must have come from part of Karnataka. That is getting bigger. Ward numbers have increased from 140 to 20. It will go to 390. Like it's urbanization. I'm just giving an example. And now NCDs, non-communicable disease. Everything is on non-communicable disease. We need to screen our population. That's what we are taking up in the country and in the state of Karnataka. Go to every house, screen for NCDs, screen for cancers, treat them, detect them early, treat them early, improve their quality of life. That should happen across. Now gradually we started piloting those things. Then improved care seeking. Now people are coming. The health seeking behavior has improved. So it has its own side effects. People start demanding good quality service. When they have better health seeking behavior, you need to provide them better facilities. That's what is expected. So those things are again challenges. Whether we are catering everything. There are some areas which need. And advanced treatments, anyway, it's higher cost because that company has invested, that whole facility has invested on research. They have developed some advanced technology. They will charge you more. Somebody wants robotic surgery, you will have to pay. Somebody wants surgery in government hospital, it is free. So things are changing. Then demand for better experience. They expect very nice room, nice facility, nice care. Automatically you have to pay more. So those are things. Then better experience or better facility will definitely cost you more. You are putting in more money there. Then biggest challenge is low penetration of insurance and other schemes. Still the saturation is very low. It is something like your taxpayer base, which is again low. Similarly, insurance has also not penetrated that much. In urban areas, in corporate setup, we have insurance companies which are penetrated. But semi-urban areas, not penetrated much. Things have improved in the last few years, especially post-COVID. Many have understood the value of insurance, but still a long way to go. Okay? Next one. So, recently we have a lot of thrust on preventive and promotive measures required. Prevention is better than cure. You read in your books. Now prevention is the only cure. You, especially cancer and all, you somehow you have to prevent. That is the best cure. So you have then transparent pricing. Here the regulations coming to play. For example, we have something called private medical establishment. In Karnataka, it's called KPME. So the mandates, the act states that every facility should display their rates. Every facility should have all the boards of consultants coming. What is the cost of each operation? They have to, in spirit, they have to follow that. Whether it is happening, the implementation, whether it is done properly, there are questions. So transparent pricing will actually improve the uptake. Now, if you know that these are the prices in this nursing home, things will improve. Then negotiating that prices is not the mind to speak on. Negotiate drug price, whether because Government of India has also put ceiling on many important essential drugs, but there are some drugs which are quite expensive. So that is how to negotiate the rate. I think they will be speaking on. But this is very important because you are spending 20% on this out of your total treatment cost. Then this is Atmanirbhar. Lot of indigenous healthcare innovations have taken place. Lot of research is taking place. Lot of research inside the country. Lot of work inside the country. Automatically the cost will come down. And best example is COVID vaccine. We developed a vaccine. We gave it to everybody at a very low cost. Next one. So we are looking at two things. So we are looking at both equality and equity. We are looking at both. Okay? See, there are gaps. Female literacy. There is a tremendous difference between urban and poor. Okay? And most important, 1 in ₹6 spent on hospitals or hospitalization in the household is financed through borrowings. 1 in 6 household, they are financing it through borrowings. Asking some friends, family members, they are putting money there. It's an issue. Antenatal checkups, better in urban, not so better in rural areas. So that will lead to vulnerable pregnancy, high risk pregnancy, maternal mortality, all those issues. Next one. So how we are trying to address the health disparities? The most important thing is universal health coverage. As per the national policy, as per the vision document of the state, universal health is the buzzword. That means anybody born and is from my state should get accessible, affordable health care free of cost or minimal cost. They should be getting it. As per my database, we have around 5.09 crore population who are eligible for Ayushman Bharat Arogya Karnataka. And we are giving them Ayushman card. We are treating them. Every month we treat 2.5 lakh people. Every year we treat 25 lakh people. That has been. But are we giving the complete quality? There are some areas where we need improvement. And this is about BPL families, those who are below poverty line. There are around 4.23 crore individuals, okay, or 1.15 crore families. And there are 19 lakh families who are APL, who are having ration card, or on 86% in 86 lakh individuals. But they have to pay 30%. Some of them may not afford it. This is about poor and APL. And there are some rich fellows who can afford insurance. There are the middle fellows who are not so poor, who are not so rich. What we should do about them? Even they can't afford health care. So this is called missing middle. These are the people who are called missing middle, and we need to cover them. That will be the next big thing which will come. Like you have to fix some premium, or you have to have, say, every month, every year you have premium of 800 to 1000, but you will cover them with 8 to 10 lakh rupees of insurance. That will definitely prevent out of pocket expenditure. So this missing middle is the next big thing which will come. Right now, Karnataka has taken lead that we are covering APL families, and they have to pay 30%. Even they should not be paying. They should be paying a premium, but they should get all the facilities of both government and private. Okay? Then comprehensive primary care. This is about Ayushman Bharat has 3 important components now. In fact, 4. But most important is, one is Ayushman Bharat Health and Wellness Centers. Not just health and wellness. It's called Ayushman Bharat Health and Wellness Centers. In Kannada, it's called Arogya Mattu Kshema Kendragalu. Okay? We have more than 9,000 centers in the state. We have more than 1.6 lakh health and wellness centers across the country. These are the first contact points at the village level. They are established at the village level. Wherever there were sub-centers, they are all upgraded at health and wellness centers. Okay? For every 5,000 population. They are working for every 5,000 population. And these are the centers where there is the first contact from that village. Even urban area we have those centers. The main job is primary prevention. They have to give a lot of preventive messages. They have to educate people. Plus primary care. All small diseases should be treated at that level. Then there is referral mechanism, secondary care or tertiary care. They are covered under Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. That's called PMJAY. The recent one has come, it's called Ayushman Bharat Digital Mission.
the technological invention which has taken place, which will keep all your records.
It's called Ayushman Bharat Digital Mission. Okay? Then there is Ayushman Bharat Infrastructure Mission. So this is comprehensive primary care is covered Ayushman Bharat Health and Wellness Centers. The assurance mode is covered Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Both are going hand in hand. That is actually helping you to reduce out-of-pocket expenditure. Okay? So health care at the doorstep. That is the concept, where you are going near their home. Then targeted health outreach. All these missions run, like Mission Indradhanush, Anemia Mukta Bharat, you are focusing on anemic patients, nutritional programs, all those things come into play. Then for backward community and tribal population, you have special schemes. In Karnataka, even for backward and SCP-TSP population, we have a lot of good schemes, including organ transplant, treatment of high
diseases, although some of the examples. Next slide, please. So,
the buzzword is technology. The biggest thing is technology. Advances in medical technology. So, then the more and more technology comes into play, you will lose human touch. Even you must have seen everybody, previously we were all sitting together having
correct? So, previously somebody is coming to
a chemist shop, the chemist was knowing his whole family and his whole history. Now we have online pharmacy. So that times have changed. So technology, the empathetic, the human touch, we have to balance. And the ethical consideration is the consent, the data security, whether it gets leaked, all those things we have to do. Then now everybody is talking about AI. There are good things and there will be a lot of side effects also on artificial intelligence. So how conservatively or how religiously we use AIs will define our future. Okay? So that is vital. Now telemedicine has come because at the village level, the infrastructure should improve. Till that time, technology has come very fast. Everybody has gone to telemedicine mode now. That's how the things have changed. Then everybody has now Apple Watch and all those big watches. So wearable devices which will give all the health indicators now. That is how the health has changed now. Then for me, that is the last word, that human touch is vital. We should not lose the human touch. Ultimately, there should be balance between technology, artificial intelligence and human touch. Because I belong to that old generation. I am 50 plus. The younger generation may think it in a different way. I don't know. Next one. So, we have to focus on value-based care. We are talking about quantity, all big numbers. Whether we are following value-based care, we need to improve on that. We need to improve the quality in care. Okay? Then we have to focus on differences in need. We government fellows are quite good in starting things, but very not so good in following outcomes. So we have to focus on outcomes. Then evidence-based medicine is vital. The research inside the country will help you. The following papers is altogether different. You publish papers, you follow Indian evidence, that will give you definition. Then different healthcare providers should collaborate together, come up with new and very affordable cost-effective things. Preventive care is vital. Prevention is
always better than cure. Next one.
Healthcare professionals. COVID has actually drained everybody. Healthcare professionals, I am talking about everybody. There is a huge demand side across the country. Are we actually catering? Right now, not so much. That's why you are seeing that new set of medical colleges, new set of pharmacy colleges, new set of nursing colleges coming, because there is so much of demand. We have to have a huge manpower. We have gradually, where our population is aging. Still we are the youngest country, that's okay, but still the population is also aging. And even in medical fraternity, the seniors are going and
Things are changing in a different way. The younger generation thinks in a different way.
then lot of burn, stress everywhere. And that's to the health workers succumbing to all the diseases, not just the beneficiary of the patient. Even the workforce is suffering. So we have to look at those things. Then the most vital.
I think this is one of those ways where you are actually building the capacity of your people. This training is helping them. Similarly, capacity building or sensitization or building your force for next generation is vital in my country. If we do that,
I think that is the way forward. We should have very strong regulatory mechanism balancing between health technologies, also giving the approval or taking the time-bound manner. I think that will define the next decade. Okay. So thank you so much. My question. Okay, thank you.
Such a wonderful talk. What do you feel? A big round of applause. Sir, this was really a very informative talk. Maybe if this was just an abstract, would you give us? Maybe one the workshop, full day workshop, information you have kept so much of information with you. It's a great thing, sir. Thank you. I request Shri Bhagavati Kanapure, sir, Drugs Controller, and Dr. Amrish, Additional Drugs Controller, to honor Dr. Suresh Shastri. Thank you, sir. Health and wellness global status. To speak on the said topic, we have with us subject expert, Dr. Preeti John, who is on virtual mode from London. Dr. Preeti John is currently the Deputy Director, MBA Health Global Business School for Health University College, London. She is the co-founder and past chair of Women in Global Health India. She is a health management consultant and an advisor for several health NGOs. She was the only Asian recipient of the Harvard Lead Fellowship in 2021. Please put your hands together for her. She has experience in capacity building of diverse healthcare human resources in developing countries across South Asia, Africa, Latin America, and has held leadership positions in different organizations. Let's hear it from Dr. Preeti John on the topic Health and Wellness Global Status.
The seminar and the kind of audience that you have managed to garner for today's session. I would like to take you over the next 15 minutes, share different examples of health and wellness from a global perspective. To kind of start this, and I think this follows what every other speaker, the eminent speakers before me, have also spoken about the challenges. So one, every country recognizes at the national level it should be an electoral issue, but at the international arena we are looking at whether health is on the foreign policy issue. We are understanding more than ever for trade, for the kind of policies on export, import, international collaboration is vital for healthcare. There's a lot of imbalance in global health spending and tremendous global shortage of healthcare workforce. We're also seeing an increase in places of conflict. So, an increase in mortality and morbidity in conflict zones, and therefore an increase even in military healthcare. We're also seeing the huge impact of climate change, floods, earthquakes, etc. And we're also seeing, as I'm sure all of you have already recognized, that the wellness economy is a multi-market. It's a huge opportunity. And it can be divided into so many sectors within it, ranging from how do you prevent aging or just the whole cosmetics, the beauty part, to spa or the wellness tourism, and definitely the whole lot which is on the fitness and mind, preventive, the nutrition part. how can all this be addressed? So there is a whole concept of leadership training. And in fact, the Global Business School of Health, where I am based, it was launched as the first business school which is in or only for healthcare. So we have a lot of pharmaceutical students along with the NHS students or from diverse healthcare professionals, all wanting to learn how to be a better leader or how to do management better. There's a lot of coaching, mentoring, executive education which is being provided in this area of leadership and management in healthcare. And this is considered vital for health and well-being. We are also seeing as part of NHS, they have launched something called well-being conversations. Well-being conversations are conversations which is basically to say, how can I support you? For example, you are doing your work, your daily routine of work, but there is a particular incident that happened. It's important to talk about as part of the wellness of the staff who are working to prevent burnout and improve resilience. So NHS has actually got a full program on well-being conversations. Now, this is another example of what is happening perhaps with you as well as other people around the world. This is an example of a person called Maya who gets up in the morning, goes to the gym, which means there's probably tracking via a smartphone. Perhaps after the gym, she has to take a certain type of supplements which she considers as necessary for her personal wellness. Then there's all kinds of even sportswear which are considered the right ones to ensure the body is kept proper while exercising. After a good food, she may go to work. She may start her work with spending some time in meditation, which she may access via an app. She has access to all kinds of food. She thinks about the calories she's having. She also thinks about what is the nutrients, whether it's organic food, whether it comes from a fair trade. At the end of the day, she may relax, again using certain products which help in relaxation. And finally, she may again go back to certain apps which can help improve her quality of sleep. And this may sound strange, but at the same time, we are recognizing that people all over the world, and we're not seeing too much difference between youth in urban areas across countries, using different tools for doing this. This is another example of where big data, we got familiar with the term artificial intelligence, we got familiar with the term big data, machine learning, and now they're talking about fabric, data lake, and these are terminologies which seem so far away, but it's coming closer to us, because maybe in your world where clinical trials and drug discoveries are so important, the data fabric is seen as one tool to accelerate the speed of clinical trials. The other example in scenario 2 is an example where counterfeit drugs is seen as a huge issue. So with the increase of fake drugs, there is also technology solution which is coming out of this big data, blockchain, the data fabric in that environment. So my takeaway from this slide to all of you is just to kind of pay attention, because this is coming not just in scientific journals, but it's coming in our newspapers. So maybe it's the headline of tomorrow of some new next technology that perhaps Karnataka will use. So these are terminologies we just need to become familiar with. This is another high potential, something which is happening. which is called the digital twin. There's a lot of research happening in US and in other parts where they're looking at, we are very familiar with our skeletal system, but here it's looking at how do you map and come up with the genome sequencing of your entire, or your data, how can you capture it? There are companies which are saying that without a change of clothes, without it being claustrophobic, without removing too many things, you can actually do your scan and get your digital twin ready. So one example is how scanning technology is changing, and how this will impact is, as from a pharmaceutical industry, it's how does this impact you? If you are able to get more data of biochemistry, of immunology, of a person, and it's 24/7 if this data is available, and if this is to make a person healthier, what is it we should be thinking about? This is an article which I saw in Nature, and this is about a study they are releasing which is going to happen over the next 7 years as they work on making this a real model. So again, I would say it may, these terms of digital twin, data fabric are things that you should pay attention to. This again is an example from an organization which is working in the health and wellness. But the point I want to make on this slide is, it's increasingly we are filling up a lot of questionnaires. And so this company, in order to provide some kind of a health and wellness solution to people, before they provide the intervention, is actually looking at understanding the person. So whether we are talking about precision medicine, we're talking about genomics, we are talking about just even in the space of health and wellness, there's a whole spectrum of data which is constantly getting collected so that the intervention can help us in a better way. And alongside that is things like what is called as closed-loop patient monitoring. This is particularly used as an example from Korea, but it could easily be across Europe, where there is tremendous shortage of people to look after the elderly. So they are looking to technology as a solution to address workforce challenge, as well as ensure medicines, access to medicines reach people in a continuous manner. Alongside this, we're also seeing, when we are talking about NCD, chronic diseases, we are looking about lifestyle changes, which the chief guest already alluded to this. Now, how do you tell people that, pizzas and burgers and all kinds of soft foods or junk food which is available may be contributing to obesity? We look at malnutrition, and we have gradations across the world. If a child is malnutrition or if a child is underweight, schools at this point were not grading if a child was obese. UK recently started sending in the schools letters to parents if their child were becoming obese. And this caused a whole lot of, as you can imagine, dilemma, because a chubby child is considered a healthy child. It means the parents looked after. But then childhood obesity, having complications for later, is being understood. And so there is a whole lot of acts in the wellness area coming up just to encourage or motivate people to change their behavior. So there are apps for the intervention, there are apps for technology to make people use those interventions, for example, to exercise. So there could be motivating apps. So it's very interesting how this entire area of health and wellness has spun off a whole set of new areas that we never thought about. We also think about tools which are not only looking at behavior change, but also apps which are looking at improving self-efficacy. so that people will actually decide if they're going to decide to quit smoking or adhere to a diet or do exercise, they will actually do it. So these are other tools which are coming in the health and wellness market to help that. This is actually a song, I'm just going to skip it for now. Go into Egypt. So Egypt, what is very interesting is, till I was doing this, I did not realize that Egypt is extremely well known for their bread. So every family, every street food has a lot of bread which is available. But they have also realized that obesity is on the rise. In one of the recent surveys, it showed that only 25% of the Egyptians are within the normal weight range. This is alarming. So, they've looked at the data in all kinds of ways. They've looked at it between girls, boys, they've looked at women, men, and obviously you can see that there's higher percentage among women than among men, and then it goes to boys. And they go into a whole lot of reasons which are cultural for this high obesity. So Egypt has been looking at, okay, what can be done to kind of change this? Because this is a basic cultural practice. They've looked at food subsidy policies, they've looked at the fact that it's a very sedentary lifestyle, they don't have public transport, you can just get into a car or public transport and there's not enough walking which is required as part of their daily life. Whereas London, it's considered the most pedestrian-friendly city. And if you just went to work and you came back, it's more than likely you would have done your 10,000 steps without doing anything extra. Because the way the environment is structured, you just have to walk. You just have to walk a lot. So how can we make it, so this is what Egypt has been thinking about. There's been an increase in ultra-processed foods, stress. So they've been looking at all kinds of ways to reduce this. And one of the ways they are looking to change this is actually through universal health insurance. So it's not only to help in universal health coverage, but they're looking at universal health in insurance as a way to fight the different barriers to address obesity. So it means that they have to work with different industries, the food and beverage industry, they have to work with education systems, as well as with the urban planning and transport. Now, when Egypt decided that they needed to address this, what they did was they looked at their own country, they looked at what was successful in their company, in their country. For example, the Hepatitis C campaign was seen as very successful. They understood the high political commitment they got, intersectoral collaboration, as well as public awareness. And so they're looking at, well, how can we use all of this, what was applied in their local scenario? So we can listen to all these global case studies, but finally, the solutions have to be local. Because what are the issues in your local context may be different. But perhaps there are some learnings we can take from these different examples. So they've been looking at stakeholders, they've been looking at where there are positives, for example, how to make the media more positive on reducing obesity, or rather making it urgent, the challenge to reduce obesity. And they've looked at the school feeding program, they've understood that the Ministry of Health cannot alone do this, looked at different collaborations. They've come up with a different kind of a school feeding program so that the youth nutrition as well as food security improves. This is a picture of their bun, which is like part of their regular life, but which unfortunately also has been one of the reasons for obesity. Another case study is from Saudi Arabia. They have released what is called Vision 2030, and it's extremely interesting because they've suddenly changed their entire health system around. They're looking at three areas. They, of course, want to be an ambitious nation. They want to be a thriving economy, vibrant society, and they've looked at how to do it in so much of detail. So the reason I'm bringing the Saudi Arabia example is because we need to pay attention to the health system that we have. We have perhaps a state health system, but how do you decode it? You know, what worked very well during COVID? How do you change some of that so that even despite NCD, how can we change and do what is now necessary for chronic disease conditions? So, for Vision 2030, we have what's called the Health Sector Transformation Program in Saudi Arabia, where they have completely restructuring the health sector, including apparently creating an absolutely new city which is coming up called NEO, which is, it's almost like a science fiction, but they are making that a reality to improve health of its citizens. So again, I would just say that, pay attention, because there are lots of things happening in terms of changes, even in other countries which are not necessarily in the highly developed, but I think the biggest innovations are happening actually in the LMIC. I also, before I conclude, I would like to just talk about two things. So all the examples till now, we're talking about, an individual health and well-being through different, whether it's through technology, whether it's through policy, whether it's through health system changing, or even what can be done at the hospital level. But this is an example which is from GSK. Now GSK has actually produced a report which is on ESG, which is environmental, social, and governance impact. Now, across Europe, ESG reports or ESG auditors are being asked to produce the report of how their companies are complying on these areas. So I just pulled out 3 areas from that report. So, for ESG, there are 6 focus areas for GSK. And under this, for example, access. This is their report which came out basically in terms of how did they adhere to access, whatever goals they had, did they achieve it or not. So they're quoting the figures of 73 million people were reached in lower income countries with their products, and how they are able to have different partnerships so that vaccines can be provided free of cost. This is another example from environment, where the company has to provide information about how they are reducing carbon emissions. And globally, organizations are finding that they have to show how they are improving on climate change, environment, etc. The other example is related to diversity, equity, and inclusion. So in that part of the report, they had to produce the audit report. They had to show how many, in terms of gender. For example, WHO brought up a report which says that healthcare is delivered by women globally, but healthcare is led by men globally. 75% of the healthcare is delivered by women. 25% of the women are in leadership positions. So these are global reports and global standards which now companies are having to adhere to. So this diversity report talks about in leadership positions in their country in terms of gender, how compliant are they? So 42% of VP and above roles are held by women globally. They also talk not just about gender, but in terms of diversity. 31.3% ethnically diverse leaders and above in the US. So, and also we know that in clinical trials, especially, there have been a lot of reports which have come out that it's only on one particular type of ethnicity that the clinical trials happen. So there is a lot of demand for data or for people to show, did you have diversity in the population when you were testing, when you were in the drug discovery phase? And the last example I just want to share, which is again, I feel is part of organizational or well-being in health, which is coming from AstraZeneca, where in their report they have to bring out about how they are contributing to the Sustainable Development Goals. And of the 17th of SDG, they have brought out SDG 3, we all know it's good health and well-being, but they have also looked at SDG 12, which is ask pharmaceutical companies for responsible consumption and production. How are they compliant? Also climate action, life on land. So all kinds of metrics organizations are now accountable for in terms of organizational well-being, as much as people are being, and for example, there are debates going on. Healthcare workforce, should they all be in the normal BMI, or should there be some consequences if they are not, or have they entered into a personal wellness program if their health, on certain parameters, if they are at risk for, let's say, NCDs or something else. So I think this topic is extremely important, gives us much to think about. And so in conclusion, I would challenge the audience to reimagine how health and wellness at the individual or personal level, to the organizational level, how are you going to make this? How can India lead on innovative practices in this area? We should not leave all the innovation to the technology and the computer scientists. I think, of course, your drug discovery papers you definitely will be having, but in terms of how can pharmaceuticals contribute even further to startup entrepreneur ecosystem, as well as, again, in the innovation, how can you do it? I think you should challenge yourself, and I'm sure, we will probably see a big difference, particularly how can Karnataka probably lead in all this. I would also challenge you because I think the pharmaceutical group, as a challenge, how can you develop inclusive and diverse leadership, and how can that help you, be aligned to global standards? And then, of course, leverage digital health. I mean, we have seen digital health as, or technology tools as a solution, whether it's workforce shortage or it is in dealing with, different aspects of challenges. Some of the solutions, even though we do talk about, yes, we must have people, we're talking about task shifting, we're looking about tools in the hands of people to do the work better. So I'm sure you're going to be having much greater deliberation and a lot more discussion. I would like to take this opportunity once more to thank all of you, and I wish the entire discussion and the seminar a wonderful learning opportunity. Thank you.
Thank you, Dr. Preeti John. It was a very informative talk. You literally taken us around the globe on health and wellness. The slides were very good. Great presentation. A big round of applause to her. Thank you so much. I request Shri B.T. Kanapuri sir and Dr. Amrish Tumaki sir to honor Dr. Preeti John by presenting a memento and certificate. I request Srimati Shailaja, Assistant Drugs Controller, to come and receive the honor on behalf of Dr. Preeti John. The certificate and the honor will be sent to her. Thank you, sir. Thank you, Srimati Shailaja. The national pharmaceutical pricing, we are running short of time. I request the speakers to complete the presentation within the time allotted. The National Pharmaceutical Pricing Authority, NPPA, is a government regulatory agency that controls the prices of pharmaceutical drugs in India. NPPA is the policy governing price control, and DPC is the order by which the price control is enforced. The direct price control order are issued by the Ministry of Chemical and Fertilizers, which is the main nodal administrative ministry for pharmaceutical companies. They are issued in exercise of the powers conferred by Section 3 of the Essential Commodities Act 1955. The objective is to make sure that the quality essential drugs are available at the reasonable prices. To talk on the topic, fixation of ceiling price under NLEM 2022, ensuring affordability, we have with us the subject expert, Sri Sanjay Kumar, Sir, Advisor, NPPA, Department of Pharmaceuticals, Government of India. Let me introduce him. Sri Sanjay Kumar is basically CA by profession. He belongs to 1998 batch of Indian Cost Accounts, joins the service in 1999 as Assistant Director in the Central Excise Commissionerate, Nagpur, and was instrumental in implementation of Excise Audit 2000, which is newly implemented audit system by CBEC. While his posting in the NITI Ayog as a Director, Northeast and UTIs, he was instrumental in island development of 5 islands in the Union Territory of Lakshadweep. He will be presenting on the topic, fixation of ceiling price under NLEM 2022, ensuring affordability. Sir, please.
most priced brands. The doctors will suggest you that as a practitioner. So mostly the doctors will suggest you that, and will buy only those brand which is prescribed by the doctor. And the trend, the market data which is available with us shows that in the most of the cases, the market share of those formulations which are high priced are higher than those medicines which are relatively lower priced. So these are the reasons which compels Government of India that we should have a price regulation on this. Next slide please. So what is the reason? So as I said in the beginning, that the goal is ensuring availability of the drugs at a reasonable price. So the price should be reasonable. When we see reasonable, we don't see that it's cheap. It should be reasonable price. Then, while fixation of the prices are done, the government also has to ensure that prices are not so placed that we are killing the innovation. Because as Dr. Priti John was showing in her, the technology is moving. So obviously when there are the innovations, there are research are happening in the skin. So whenever the new formulation will come, obviously it will have a cost of expenditure. So the government tries to balance while pricing that the innovation is also not killed. So innovation also requires to be promoted. For this purpose only we have certain provisions in our DPCU where we give incremental prices like para 11 under which we give the incremental prices for the innovation, under para 32 of the DPCU under which the patented product, the Indian patented products gets exemption from the provisions of the DPCU for a certain period. When we are talking about the price fixation, so it means the government is not manufacturing these drugs. They basically it's by the market. Though there are the PSUs who are manufacturing it, but primarily it's by the private entrepreneurs who are manufacturing it. So why we do it? Because the drug has been declared as essential commodity under the Essential Commodity Act 1955. So since it is an essential drug, it has to be regulated. Then DPCO, that is the drug price control orders, have been issued by under the section 3 of the by the Department of Pharma. Earlier it used to be Departments of the Chemical and Fertilizer, Ministry of Chemical and Fertilizer. Now under the Ministry of Chemical Fertilizer, we have a separate department, that is Department of Pharmaceutical. So when I am talking about the current scenario, it's a Department of Pharmaceutical. The DPCO 2013 has been notified, taking with the intention to implement the National Pricing Policy, National Pharma Policy 2012, which has the approval of the cabinet. So what is the intent of the government that has been captured into the Pharma Pricing Policy 2012, and that is being implemented through the DPCO. We have the DPCO since 1979. The first DPCO, that is the drug price control order, was issued way back in the 1979. Then it was revised in the 1987, depending to capture with the developments in the industry. Then again it was revised in the 1995, and currently the DPCO which is under force is DPCO 2013, which is implemented for the regulation of the prices. What are the differences that will come to in the subsequent slides? Next slide please. So In the, these are the salient features of the DPCO 2013. So in the DPCO 2013, we fixed the ceiling price, and ceiling price is a fixed for the scheduled drugs. Now what is the scheduled drugs? Let me just touch upon that. There is a national list of the essential medicines. So there are the committee of the experts who, based on their market assessment, that which drug is more required depending upon the diseases and all these things. So based on that, national list of the essential medicines are issued by the Health and Family Welfare, Ministry of Health and Family Welfare. The latest one has been issued by the Health and Family Welfare in September 22, rather on 30 September 2022, that NLEM was included. Then the same NLEM is included as a part of the Schedule 1 of the DPCO. There are, why this is mandatory? Because they are, even the Supreme Court is concerned about the health of this. So even the Supreme Court in their judgment has said that the essential drugs should not go out of the price control. So even the Supreme Court has decided that it should be there. So whatever is there in the national list of the essential medicines, that is covered into the Schedule 1 of the DPCO. And for those drugs which are covered in the Schedule 1, we fix the schedule price. That is called the schedule price. The interesting fact is that if you see the total market, only 19% of the pharmaceutical drugs which are available in that are covered under the Schedule 1. So this is also an interesting fact that only 19%. Many a times the industry will have this complaint that we have interest, but only 19% is covered in this. Then we don't fix the prices of the non-scheduled drugs, because the non-scheduled drugs are there. So those drugs which are not scheduled are the non-scheduled drugs. So we don't fix the prices of the non-scheduled drugs. But here there is one thing, this is one again 81%, so the remaining 81% is this. But it is not out of the control. It is not out of the control, again I will say, because if a manufacturer starts manufacturing a non-scheduled drug which has some component of the scheduled drug, then again we fix the price, which we call retail price. So that retail price is also fixed, but primarily we fix the prices of the scheduled price. We fix the selling price of the scheduled price. Here one more catch is there. The selling price is the highest price at which the drug can be sold. It's not necessarily that all the manufacturer has to sell at that price only. They can sell at any price below that, but they cannot sell at a price higher than the selling price. So that is the upper limit. As the name itself says, that is the ceiling. You can't go beyond that. You have to remain within the ceiling. Now, how do we prevent this loophole? There are some loopholes. Say one company who is manufacturing a scheduled component, he finds a more profitable non-scheduled drug to be manufactured by him. So he can stop and he can start manufacturing of the non-scheduled drug. But no, it is not permitted. A manufacturer who is manufacturing scheduled drug, he cannot discontinue the product without the permission of the Government of India, which is delegated to the National Pharmaceutical Pricing Authority. So only if you are allowed by the NPPA to discontinue, then a manufacturer can discontinue. There are the manufacturers who still say no, we want to discontinue it. Then there is a provision in the DPCO, that is para 3 we call. So that is invoked, and if the para 3 is invoked, a manufacturer cannot discontinue. So depending upon the assessment of the requirement of the drug, the availability of the drug, the availability of the competitors in the market, a decision is taken. So simply it's a that anybody cannot discontinue it at its own. He has to take a permission. And that too, if he wishes to discontinue, he cannot discontinue immediately. He has to issue a public notice and he has to give at least 6 months time. So that many times you will find that a person who is having a disease what we call lifestyle disease like diabetes and BP. So if they are used to taking a particular medicine, no, they will be taking that particular medicine. So if it is stopped immediately, next day he will get worried. So a 6 month time is given. It has to be notified by the company through a public notice, and so that the doctors can also prescribe the medicine. The users can also have this. So he has to give us 6 months notice. He cannot discontinue it like that. These ceiling prices are not fixed every year. The ceiling prices of the scheduled drugs are revised every 5 years. Generally every 5 years. But in between, if there is an increase in the prices, so that is because of that the company has a wholesale price index effect. That is, we all know that there is a consumer price index, there is a wholesale price index, so that changes. So if the wholesale price index has changed, so based on that, the companies are allowed to increase the price by the maximum limit of the WPI, with the and again it's notified by the NPPA. So with that, once in the year, at that too, in the month of April or May, he can increase the price. So he has to avail the increase in this. Here again, the interesting fact is that he is not required to avail it mandatorily. It's his own choice. Say if the WPI increase is coming to the 5%, he may either choose not to increase any price, or he may choose to increase it by only 2% or by the 3%, depending upon the market dynamics. But generally once in a year, the WPI increase is also given in respect of the scheduled prices. As you will see for the non-scheduled drugs, as I briefed earlier also, they can avail maximum of the 10%. That is whatever the price was prevailing during the preceding 12 months. So they can avail that 10%, maximum of 10%. Here again, it's not compulsory. Many of the companies may take, many of the companies may not take. And generally our analysis has shown that the companies are taking this increase at an average rate much less than 10%. So they also have to see their business dynamics. So accordingly they take the IA, but the maximum cap is there, so that we make it comfortable and affordable to the all. One fact Dr. Sastry was telling, if you guys have noted, that negotiation of prices. Unfortunately, government cannot do the negotiation of the prices. We have to regulate it. Yes, when there are the procurement system under the various government schemes, so that time the buyer or the procuring agency, like there are the health centers or the state government's health departments are there, or the hospitals are there, who buy medicine for their own schemes. So in that they can negotiate, but the government do not negotiate. Then what happens? If you feel that a drug price of a particular drug, which is not a schedule, is unreasonably high, so in that case the government has a provision which is called as para 19 of the DPCO 2013. So by using the powers of the para 19, we can fix the price of that particular formulation or the drug or the medical device. So that is also done by the government. In subsequent slides, I will show you that some of the examples then when we have done it. But as Mr. Sastry was telling, my colleague has already left, but we don't negotiate, we regulate. Wherever it is required, we regulate it. And that's always done in the public interest. Next slide, please. So now, this is how the DPCO has evolved, or the pricing of the drugs has evolved. As per the National Pricing Policy 2012, we don't do the pricing of the KSM, that is key starting material. We don't do the price of that. We don't do the pricing of the intermediates. Whatever the byproducts comes, so that also not regulate. Now comes the API. So API, that is commonly known as a bulk drug, that was regulated earlier. So in the under the DPCO 1979, DPCO 1987, and DPCO 1995, the cost of the API was also regulated by the government. But since the industry, the market has matured enough, so now the government under the DPCO 2013 does not do price the API. API, that is the active pharmaceutical ingredient. That is the basic raw material with which a particular formulation is manufactured or produced. So under the DPCO 2013, we do the pricing of the formulation only. Or now there are some medical devices like Cortisone. So that is also one of the scheduled medical devices. So we do the pricing of that. So that is because that is the essential medical device. So the pricing of that is also done. Sorry. So what is the theory of this? The theory is that what is essential? As I said in the beginning, that we do the pricing of only the essential drugs, primarily. We do the retail price of the new drugs also, but primarily the NPPA or the Government of India does the pricing of essential drugs only. Currently, the national list of essential medicines, which is in force, that is NLEM 2022, which was released by the Ministry of Health in September 2022, and the same was adopted as a scheduled one in the November 22. Now, how do we do the pricing? That is one of the, there are the technical things, but now the prices are market based. We don't go into the, we don't go into the cost, because going into the cost, there are the number of the industry. If you see the market dynamics, there are around 3,500 companies with about 10,000 manufacturing units for the formulation. So doing costing is not very convenient thing, and going into the costing is also not the intent of the national pricing policy. So we do the pricing by the based on the market data. So what is this market data? The market data that we see that okay, this particular formulation, say for take example paracetamol. So paracetamol is available in the market under 7, 8, 10, 20 brands. So at what price they are selling? So say our selling price, they cannot violate our selling price. The selling price says, for the convenience we are taking the selling price at 10 rupees. So the 10 rupees is the selling price for the paracetamol, one tablet of the paracetamol. What we see at the end, that out of the 20 companies, 6 companies are selling it at the price of the 6 rupees. 2 companies are selling at the price of the 10 rupees. Remaining 4 companies are selling at the price of somewhere of the 7 rupees or the 8 rupees. So we feel, the government feels that the cost of production of these or the average can be, the average price is affordable or is the real cost, or you can say on the price on which the companies can sell. So adopting this methodology, that the market data, we average it and we revise it. So whenever there is a revision in the selling prices, it will go downward. So in that case, the selling price earlier which was 10 rupees for the paracetamol, that if we average out, that will become around 8 rupees. So what is the impact of it? The impact of this is the manufacturer who was selling at 6 rupees, he is not supposed to decrease his price. But all those manufacturers who are selling at a price higher than the 8 rupees, they have to decrease it compulsorily by whatever the price they were selling high, so they have to come down at a price of 8 rupees or below that. So now the pricing is done based on the market data. I think if we go into the detail, that will become more technical. Next slide, please. This is the summary of the price fixation. So, as on date, if you say as on date, the selling prices of the 915 formulations are under force. 914. Total, I think, formulations are about 1000. So, remaining are also under EA. So, total 915 formulations are there for which the selling prices are in force. Out of this 950, 691 has been fixed under the NLEM 2022. For the remaining 224, since we are in the process of the collection of the data and there will be certain other things, so for the remaining 224 products, we are collecting the data or are under consideration, and very soon this will also be fixed or notified. But as of now, 915 are there for this. When we do, as I said, when we do the refixation, what happens? The prices reduces. So when for this 691 drugs we have done the fixation, the prices have reduced by 16.71%. Roughly you can say the drug which was available for the 100 rupees in the market, now that should be available at around 84 rupees or 83 rupees. So there, whenever the price reduction is done, so this is one of the indications that by fixation of the selling price of the formulations, this is made affordable to the public. It's not like that the prices, everything is increasing, so the prices of the drugs will also increase. But as per the DPCO provision, since we have to give the WPI impact also, so after giving the WPI impact, the net impact of this is coming to around 6.73%. So just because of the NLEM 22, the prices have been reduced by around 6.73%. Apart from this, as I was telling, NPP has also fixed the price of the 2,494 new drugs. When we say new drug, what is new drug? Say if a manufacturer is manufacturing a scheduled drugs and he is also bringing a drug which has a component of the scheduled drug. So that also is not out of the control. That product is also under control. So for that we fix the retail price. So we have fixed the retail price of around 2,494 drugs. One basic difference which I would like to say between the selling price and the retail price is that the selling price is for a formulation. That is, say selling price of the, if you are talking of the paracetamol, then all the manufacturers in the country who are manufacturing paracetamol, the selling price is applicable for them. But the retail price is applicable for that particular company for which it has been fixed. So the retail prices fixed for a particular formulation can vary from the one company to the another company. But this is also has been fixed. As we are talking about the negotiations or the exceptional powers, we have in the 2014, way back in the 2014, the government felt that the prices of the cardiovascular drugs and anti-diabetic drugs is a little high. So the government has exercised the powers under the para 19, that is our powers under the exceptional circumstances, and the prices were reduced for those prices. So we keep doing that also. It's not like that if you are non-scheduled you can remain open. So we do that also. Coming to this, now the one of the major relief which has come to the public by way of fixation of the ceiling price, that is the ceiling price of the coronary estates. Prior to 2017, the coronary estate was not in the 2016. Coronary estate was not an essential medical device. But in 2016, it was brought as a essential medical device, and the first time the price was fixed for this also in the February 2017. What is the impact of that will come in the subsequent slides. Apart from this, the government has also fixed the price of the ceiling price of the orthopedic knee plant. Now, here I will tell you that orthopedic knee plant is not a scheduled medical device. But under the exceptional circumstances, the government has issued the ceiling price for the orthopedic knee plant also. The impacts of this, whatever is the impacts, we have some slides, and so in that I will show you. Apart from this, we have fixed the trade margins for the anti-cancer medicines, and when we fix the prices of this anti-cancer medicine, which is a nowadays major concern for everybody, the prices came down by around 90%. So I hope everything is well. Okay. So it was reduced by 90%. Similarly, during the COVID period, everybody was running for the pulse oximeter, oxygen concentrators, so thermometer, BP meter, and the new brands came in the market and the prices were exorbitantly high. So in that case, the government intervened into the 2021 itself, and the prices of the essential devices like oxygen concentrator, pulse oximeter, blood pressure monitoring machines, nebulizer, digital thermometer and glucometer were capped. So capped, when we say that if you are selling at this price, it will be capped to this. There are the methodology which we call trade margin rationalization methodology. So under this what happens? Say if a manufacturer is selling to the retailer, what he will do? This is the chain. He is not selling it directly to the consumer. So he will sell it to the retailer. So he sells at 100 rupees. But the MRP printed on that is say 1000 rupees. So in that case what is happening? The manufacturer is able to recover his cost and the profit by selling at the 100 rupees itself. But to the consumer it is available at a price of 1000 rupees or a price which you can negotiate with the retailer something below that. So that was the only thing. So government intervened and the prices of this were said, we will also know you can have a maximum trade margin of 70%. So it was capped on the 70% and that was issued. Next slide please. So now this is how the government endeavors to make these essential drugs and devices affordable for the citizens of the country. You see, this is the data. As you can see, prior to this fixation, I said that government has fixed the ceiling price of the coronary stents also. So there are the two types of the coronary stents. So one is the drug eluting stents, another one is the bare metal stent. So prior to fixation of the ceiling price by the government of India, the coronary stents was available at a price of average price, somewhere below this, somewhere above this, but at an average price of rupees 1,21,000. When it was capped, that time it was capped, it came around 22,000. But now with the annual increase and all these things, as on date, even after, you can say after 6 years of the fixation, after giving the annual increase, it is priced at 38,265. So there is a reduction of around 68%. Similarly, the bare metal stones, which were averagely priced at rupees 45,000, today it is available at the rate of 10,500 rupees approximately. This one step of the government has made an annual saving of the consumers. When we talk about the annual saving in respect to the pharmaceutical formulations or the medical devices, this is not the saving of the government. This is the saving of yours, it's a saving of mine if you are the user of it. So this is leading to the saving of 14,276 crore annually, every year. And these are the actual data calculated based on the average sales by the companies. Next slide please. Similarly, you can see about the orthopedic knee plant. These are the simply data, but this should be seen carefully because this is what is impacting you. So there are the varieties. I think we should not go into these many details, but you can see the knee implants which are available in the range of rupees 1,60,000 to 2,80,000, that is available today in the range of 66,000 to 1,38,000. This is again giving the consumers an annual saving of around 1,500 crore rupees annually. Next slide please. Same is here for the anti-cancer drug which was done in the February 2019. So again here you can see there is a saving of the 984 crore annually to the customers. Next slide please. Now as we say that the NLEM is revised based on the market requirements. Market requirements say that which disease is more causing problems for the public and affecting more people and which medicines are required. So new medicines are also included into the list. So when this NLEM 2022 was brought, around 74 or 90 drugs was included as a new drug. So if you see these examples, before these drugs were included into the schedule, because it was not included into the schedule, so for these the prices were not fixed by the government. These were the prices which were charged by the companies or printed by the company or the manufacturing company. So if you see here, one of the product, that is Meropena, which was available in the market at the rate of 4,400 per vial. It's not for a complete treatment, it's for the per vial. That has been brought down to 850 rupees. So obviously this will make the particular medicine more affordable. And this is a medicine which is used in the hospitals generally. So as I said that the information is symmetry, हमें पता नहीं है. The doctor has written this or the doctor has already administered this to me. Okay, now I have to pay. I don't have any choice but to pay it. So I am paying it. Okay, so these are the drugs on which we did it. So this has resulted into the price reduction of. Similarly, you can see there are others. So from 100 it is brought to the 46. Then similarly 1500 to 1035. And see, this is the Metrozomic. This was available at a price of 13,600, this is 13,700 you can say. which has been now fixed by the government as the 4,692 rupees. So this shows that the fixation of the ceiling prices, whether it's under NLEM 2011, 2015 or 2022, this has always, the intention of this, what we have been able to achieve, was to make the drugs to the consumers at an affordable rate. Next slide please. So as I said, under NLEM 2022, so far NPPA has fixed the price of the 691 formulations. So if you see category wise, that for which category, but that will be for the experts to understand. But as a common user, if we see, there is an annual saving of 3,578 crore rupees annually. So these all the savings are to the consumers. If we talk about the effects of the ceiling price, the total ceiling price. So when NLEM 2011 was fixed, the annual saving was 2,423. When the NLEM 2015 came and the prices were fixed under NLEM 2015, the consumers had additional saving. So you cannot say that the savings of the NLEM 2000 have been subsumed in this. No, this is the additional saving to the consumers of the 2,600. Similarly, there are all the parameters roughly which we categorize. So next slide please, next slide please. So if you can see here, so these are the annual savings which is going to the consumers, and the estimated annual savings to the consumers is 26,754 crore annually. So this is how this is made affordable to the consumer. Now we fix the prices, but if the consumer is not aware of that, say the selling price is 5 rupees and on the packet itself the selling price is fixed at 10 rupees. How do you know that the price is 10 rupees is higher or lower or what? So in 2022, August 22, which was the 25th year of the NPPA's setting up, so that was our 25th year. So in that, an app was launched which is called Pharma Sahi Daam. This is available on your mobile. You can download it from the This is for the both Android and Apple, everything is available. Okay. If you put the name of the medicine on that, then you will find the selling price, the real selling, whatever the selling price will be fixed. So the information will be available to you. Similarly, along with the prices, you will also be able to identify that this formulation is consisting of which drugs and is there any alternative is available. But again, that is suggestive only. That is not prescription by anybody. So that suggests only that okay, so the same medicines are available by these names also, and the prices of that are these. So that can be. So this is how whatever we do, whenever the price is fixed, immediately a notification is issued for that, which is available on the website. Nowadays everybody is tech savvy. We look for the internet very often. So all these notifications are available on the website of the NPPA. You can go there, you can find out, you will find the selling prices or the retail prices which has been fixed for by the government. So NPPA not only does NPPA, or I will say the Government of India, not only fixes the prices to make the drugs affordable to the consumer, but also ensures that this information reaches to the consumer. And the PMRUs, as we have said, the PMRUs always makes these awareness activities wherein on the various topics are there. So on that they will keep doing it, and one of the role is in that to make aware the consumers that what precautions are required to be taken by a consumer at the time of the purchasing of the medicines. So this is how we do. I had a question answer session also, but I think we are running out of the time. So for now we will skip to it. So thank you from my side for a patient hearing. So thank you for a patient hearing. I hope that whatever the information I have tried to share with you in a small time would be helpful for you. Thank you. Here only.
Thank you, sir. You have given us the insight of how selling prices are fixed of essential drugs. It was a very informative talk, very elaborative. Thank you so much. I request our drugs controller, Shri Bhaguji Karnapura, and Dr. Amrish Tumiki, sir, to honor Mr. Sanjay Kumar. Thank you, sir. We are really running short of time. I request the coming speakers to please restrict to 10 minutes only, please. It's a request from all of us. Access to the medicines is a critical factor to ensure healthy lives, to promote well-being of all people of all ages. Medicines exist but are often inaccessible for reasons beyond control. They may be too costly. Purchasing them may burden household finances, risking poverty or debt. They may be in short supply due to delivery issues in distribution channels, making continuity of treatment difficult. In recent years, many countries have made notable progress. Affordability of priority medicines have increased. Supply of priority medicines have become steadier. Flexibilities in global trade agreements have been leveraged to reduce the price in certain countries. The next topic of today's session is strategies to improve the availability and accessibility of affordable medicines in global scenarios, contribute to better public health outcomes worldwide. The subject expert of this topic is Dr. G. Jagadish, former Senior Expert Center for Drug Evaluation and Research, USFDA, Maryland, USA. He is on a virtual mode from USA. Dr. G. Jagadish holds a bachelor degree in pharmacy from Bangalore University, masters from All India Institute of Medical Sciences in New Delhi, and a doctorate in pharmacology from Banaras Hindu University in Varanasi. He is a retired senior expert pharmacologist serving more than 32 years at the Office of Cardiology, Hematology, Endocrinology, and Nephrology, Center for Drug Evaluation and Research, US FDA, Maryland, USA. He was an adjunct scientist at the NIH Bethesda while working at FDA. His expertise is cardiovascular and autonomic receptor pharmacology, G protein coupled receptor, and signal transduction. He has authored and co-authored several articles, review articles, book chapters, and edited 4 books. Presently, he is a distinguished visiting professor to various pharmacologists colleges in Karnataka. Let's hear it from Dr. Jagadish. Sir, please.
billion people lacks access to medicines. Fortunately, we have competitive pressure coming from India and China that help lower prices indirectly so that inexpensive medicine becomes very inexpensive. So in this talk, I will be overviewing the factors that affect availability, accessibility, and affordability of quality medicines globally. Also, I will present challenges and strategies in combating these issues. Finally, I will describe the recent sources and challenges faced by low, middle income, and high income countries. A new chemical or biological that starts from the laboratory and passes through several phases in the clinical, preclinical, followed by clinical, and then reaches the hands of regulatory agency scientists. In all these stages, the two mantras what they have is safety and efficacy. These are the two principal factors on which the drugs are being approved. When the brand name drug comes out, it's already lost about 50% of its time. That is, the patent is because it takes about more than 10 years to move in this pipeline, costing about $2.2 billion, and then develops, generates biosimilars when the brand patent expires. Whether it is the generic or biosimilars or brand name drug, they should be made available, accessible, affordable globally to the debilitating patients. That's the main issue which is people are talking about it now. And let me give a small definition about availability. That is the quantity of medicines required in relation to its presence health facilities like primary health care centers or hospitals or in the pharmacies. They should not be starting as no rationing of the medicines. Accessibility, where people can access and purchase medicines on a convenient location so they do not have to travel a long distance to get medicine. That is, very easily they are able to access medicines. Affordability is the copay for the medicine should be low. That means it should not cost too much money for them, should be affordable, and people are able to not to go bankrupt for buying the medicine, or they are able to not make them to starve because of not available at a reasonable price. What are the factors that affect the availability and accessibility of this medicine? There are several factors which affect, like the quality and quantity of medicines required is very poor, disturbances in the supply chain, and also hospitals are not able to have an adequate supply. Primary health care centers also do not have, or some people due to hoarding, not also create artificial shortages, improper distribution, the patent system, market structure, and pricing policies. Newer agents when come out in the market, people definitely would like to have a newer agent compared to the old one because they're more efficacious. And we know that the quote of diseases, non-communicable diseases, cardiovascular disease, followed by cancer, respiratory and diabetes, and these patients are very expensive ones. The one new medicines. Health financing mechanisms coming from the government or from the health administrators that should be made available to the public. Different countries face different challenges in this process. What are the strategies to improve the availability of these medicines? Consolidate and apply governmental purchasing power, strengthen the formulary design and improve drug valuation, and also we should have the quality of assured generics and biosimilars when they are available. The people should have a trust in those generics and biosimilars. Increase transparency of financial flows and profit margins, eliminate misapplication of funds and inefficiencies that artificially inflate the drug cost. Modify the existing legislation so that there should be competition when the generics are available. Implement innovative insurance benefit designs that encourage patients to choose high-value care. Regarding accessibility, promote the production and distribution of generic and biosimilar medicines. Of course, next speaker will be talking about this generic and biosimilars. The patents, 20 years, as I said earlier, that is 10 years already gone in pipeline itself. And however, keeping the IPR issues, we should be able to negotiate the drug form so that the patent drugs can be available at a lower cost. And patent drugs usually negotiation also may reduce the price of this drug to 50% level. Governments can implement price controls to ensure that medicines remains affordable and also they can buy bulk purchase. Fortify healthcare financing systems, encourage collaboration between the local government, state government, central government, as well as the various NGOs which are working in this direction, and also the pharma companies, so that they can address the specific health issues. Increase funding for R&D of medicines for diseases, especially for rare diseases where only a couple of hundreds of people are suffering. For them, nobody wants to take up the research in that direction. For that, you have to give a tax break so that the company can invest money and do some research on this one. Support health education and awareness campaigns, implement programs that allow faster access to essential medicines, encourage donor countries and international organizations to provide financial support. Summing up all these factors, we know that there are multiple stakeholders in this getting this drugs available to the debilitating patient. That is the government, civil society, pharma companies, international organizations like WHO, UNICEF, Gates Foundation, NGOs and civil society. These are all things that come together to make these medicines affordable to public. Now I'm coming to the last segment of this term, how these issues are being tackled by various countries. Depending upon the economy, we say that low-income countries, middle-income countries and high-income countries, how they face these challenges, how they are able to solve these problems with the time. Of course, many issues are still lying there. For example, I'm taking with Malawi case. In Malawi, excuse me, healthcare infrastructure is relatively underdeveloped, especially in rural areas, and that makes the availability of medicine is very difficult. People may not be able to access the medicines at the right time. Some of the medicines, in general, 50% only people will be able to avail this medicine. Some of the medicines are not available, especially, for example, like ethosuximide, which is an anti-epileptic drug, it's 0% available, whereas antibiotics are 100% available. This type of discrepancy possibly upsets the public, and that's why they're not able to get medicines at the right time, at the right place, at the right price. Now, generics availability should be made more available, but however, their availability is about 8% in the public sector. In Malawi, healthcare is provided by both the public and the private sector. The Malawian government, along with international organizations and NGOs, have been working to improve availability and accessibility of affordable medicines, and people also should be told about they should have a trust in the generic medicines because the quality is being improving, and continued provision of free public health care is still a critical importance, but the foreseeable future until further financial mechanisms have been explored by the Malawian government. Taking up the example of the middle-income countries like Brazil, they are doing a very good job. The government has implemented several policies and programs providing free healthcare services as well as free medications. And their industry is also very robust industry they have. But however, still gaps exist in the quality, accessibility of quality medicines because it depends upon the income level, education level, and where the people live, rural and urban. So this possibly some interest will be there. Because of this, Brazil has a strong regulatory agency and also thriving pharma industry. They have a strong generic drug market which people can afford to purchase this one. Still, some of the strategies adopted by the Brazil government is expanding the coverage and scope of programs, regulating the market to prevent price gouging, unfair competition and anti-competitive practices by drug manufacturers. Addressing the social determinants of the health may be able to get access to these medicines by people. Coming to the high-income countries, for example, taken of US where I am living here, and healthcare system is very complex in the US because a lot of players are here, the state government finances and the federal government as well as the industry people. Normally we pay only about between 20 and 30% co-pay for our health insurance, about 70% is subsidized by the employer. That makes it great. But in spite of it, still about 9% of the population are underinsured. So many reforms have taken place so that our co-pay cost of the medicines are low. Generic drugs play a vital role in facilitating access to life-saving medicines that have the same quality, safety and effectiveness as their brand name counterparts, and they are sold at lower prices. Brand name as well as generic, both of them costly, but however, the generic are cheaper, and invariably the physician prescribes a generic unless you opt for a brand name which is very expensive. In the US, we pay very high price for the brand name drugs, but not for the generic ones. And there was a report from the National Academies of Sciences in 2019. They made several recommendations, that is, among different population regions in the US, such as rural versus urban, low income versus high income, uninsured versus insured individuals, and also racial and ethnic minorities, and also older versus young adults. So there are a lot of problems even at this stage to get affordable medicines for all. But a lot of reforms are going on to lower the drug prices and increase competition, allowing Medicare and Medicaid programs to negotiate their drug prices with the industry so that to bring down the cost. And also, of course, the regulatory agency is after getting approval of more and more generic drugs. There are plenty of generic drugs in the case. You know that production is very high. They established drug companies to review drug prices and set payment limits, enforcing antitrust laws and preventing anti-competitive practices by pharma companies. Expanding access to health. Now this has been introduced about 10 years ago, that is Affordable Care Act, where everyone can get insured for the health, and this reduces the out-of-pocket cost and is low co-pay for the medicine. Providing education, counseling, medication awareness, management, social support, and improving access to primary care, preventive services. Coming up to the summing up my whole talk. Of course, I have to summarize because they said I should finish in 10 minutes, so I have to hurry up and not to lose the time. And as you see this summing up slides, an availability of affordable medicines to the public means people can access and purchase medicines at reasonable cost. Reasonable cost means it should be less than their daily wage. Affordable medicines are vital in improving the healthcare outcomes, especially in regions where access to quality healthcare is limited due to economic constraints. There are many factors that affect the availability of these medicines, such as patent system, non-availability of generics and biosimilars, that we should make it to be more available, because again the quality is the more important. People should have a trust in generics and biosimilars, the market structure, the pricing policies, the supply chain, and health insurance. Health insurance should be available for all people. Ensuring affordable medicines can markedly impact public health and play a crucial role in managing both communicable and non-communicable diseases worldwide. Thanks for your attention. Thank you so much.
Thank you, Dr. G. Jagadish, sir. It was a very informative, very broad presentation. Thank you, sir. I request our Additional Drugs Controller, Dr. Amrish Tamugi, sir, to honor Dr. Jagadish, sir. I request Dr. Kempaya Suresh to come and receive the honor, accept the honor on behalf of Dr. G. Jagadish. The memento certificate will be sent to you, sir. Thank you. Thank you, sir. Thank you.
Thank you.
We have heard about the strategies to improve the availability and affordability of essential medicines globally. Now let's see the Indian scenario. To present the topic, role in pharmaceutical manufacturers to ensure availability and affordability of medicines, Indian scenario. We have with us Shri Sunil Athavar. He is the chairman and MD of Group Pharmaceuticals with more than 35 years experience in the pharmaceutical field. He is credited with launching 10 first-time products in the Indian dental segment through partnership with leading Indian and international universities. He is the past president of KDPMA, senior vice president of the Federal of Pharmaceutical Entrepreneurs, vice chairman, National Alliance of Pharmaceuticals, also associated with pharmacy colleges as governing council member, and member of planning, monitoring and evaluation board. Let's hear it from Mr. Sunil Atavarsa.
Thank you. I'll also try to be very fast, I think. So I'm here on behalf of the manufacturers and in the entire health and wellness space. I think the manufacturers also have a very important role to play. This delay is not my fault. So I started my career as a medical rep. So detailing, which was 5 minutes, we could have sometimes able to do in 30 seconds. Sunil, just check. So again, to my topic, which is given as the role of pharmaceutical manufacturers in affordability and availability of medicines, the Indian scenario. So let us look at the Indian scenario, what it is. Next slide, please. So the Indian scenario actually, as per data that we have, 38% of our population, I think you'll have to keep moving the cursor, it is in animation mode. So 38% of our population is covered under the public health sector, where medicines are given free, that is through the ESIC, through government programs and through various semi-government programs like the railways and things like that. So 38% of the population, the issue is not about affordability because medicine is given free. There the problem is about the number of medicines that are available, but at the same time 62% of the population actually is buying medicines on their own. We have no insurance on medicine, so even if we take a Mediclaim or things, it's hospital that is covered, but not medicines. Very low per capita income. And also in terms of geographic area, when we talk about accessibility and availability, we have a very large geographic area. But the Indian scenario as of today is that we produce the lowest priced medicines in the world. And in spite of all our challenges, in spite of having the fact that we have a very wide area, our products are available in every nook and corner. So that is thanks to the Indian pharmaceutical sector, that is the retail chemists, the companies, the medical reps, the healthcare workers. Even during COVID, the one story that was not told, and the whole discussion was about vaccines and other things, it was the fact that in 2 years, there was not a single complaint of any medicine not being available in the most remote place of India. Whether it was a cardiac product, a diabetic product, any single product. And I think that was an untold story. And I think that's what the Indian pharmaceutical industry and the healthcare sector has worked on. So, but it's not that that is enough, because as we've seen, we still have a lot to do. Next slide, please. So what is the role of the pharmaceutical manufacturers? What can we do better to make it more affordable? One is we can definitely collaborate with regulatory bodies to ensure compliance. In terms of cost, adhere to all guidelines in letter and spirit. I have put that because we have seen very often how companies, as soon as something is announced, the companies all of us start thinking how to circumvent, the pricing. So I think companies have to follow in letter and spirit, and quality is the foundation of any affordability and availability. And we should be, Indian companies have to work a lot on improving our name in terms of quality. Now, just a recent example on the cough syrups. I have many friends and family calling me to asking me whether taking cough syrups is safe, even in India. So that is the value of quality when it comes to affordability and accessibility. Without quality, those mean nothing. What else can we suggest to ensure medicines are available? Next slide, please. So one is the industry can explore partnerships with government and NGOs to expand the access to essential medicines. One is by ensuring better participation in government tenders by removing monopolistic clauses. So most of the government tenders work on L1 price. We have been advocating to the government, to the association, that you have an empaneled number of companies who meet a certain standard in quality, and you have a price. So you are not forced to always buy from one person. And that is why even though Karnataka and many other states have a very good medicine procurement policy, but you still find shortages because there is one or two companies who are supplying. The other thing is, always there is a list of medicines. Maybe we want to expand that list as market dynamics change. And I think if you focus on the top 1,000 brands, you will get a very wide spectrum of products that need to be available under the government program. So I think these are two things that we could suggest from the industry to the government, that A is to participate in, more companies should participate in tenders, and B, we should expand the list of the medicines that are covered under the tender programs. Next slide, please. Definitely, we need to adopt efficient manufacturing practices to become sustainable in improving our, keeping prices low and improving quality and making them accessible. We need to upgrade our quality management systems. We need to make supply chain more efficient. Today, 40% of the cost of medicine actually goes in supply chain. So I think there's a chance and scope to become more efficient there. We could invest in incremental innovation to bring down the cost. Simple things like improving shelf life. If we can make the shelf life of products from 2 years to 3 years, or from 36 months to 42 months through some collaborations with academia or to the NIPers, that would help. We need to build economics of scale. Our population is large, access is still low, the expected growth is very high, so companies need to be bigger. Currently, most of the manufacturing is happening on 3 or 4 clusters. Like in the north, we have Himachal and Uttaranchal, or Gujarat, or Bangalore, or Hyderabad. I think if we want to keep medicines more affordable, we need to have more clusters. We need to invest on import substitution. Government has given a lot of incentives for import substitution, the PLI schemes. I think we need to move in that direction and collaborate with innovators, because to bring in new drugs, it's good to start collaborating with innovators to bring the latest products into India so that they are accessible to companies. Like we are seeing in the top 10 companies globally, hardly 4 or 5 are in India. They are not coming to India because of the cost and because of the affordability, means the availability. Next slide. Another way to keep industry can work with the government is to engage to come up with long-term sustainable plans. We could suggest that currently the PMJY scheme, the Ayushman Bharat, is more for, again, tertiary care. Maybe OPDs come into that. We have always recommended that even though the Jan Aushadhi stores, we have, I think, 8 or 9,000, but still, if from my house, the grocery store is about 8 kilometers away. So if somebody from my house wants to buy, they have to take a bus and they go. So we have recommended to the association that there should be a Jan Aushadhi shelf in every chemist shop. So in one way, 8 lakh chemist shops can have access, and it would be left to the person when he goes there whether he wants to buy a Jan Aushadhi paracetamol or he wants to buy a branded paracetamol. Then to engage with stakeholders to bring a rational prescription policy. I think affordability is not only about the cost of the medicine, but sometimes your prescription has one product that is helping you, and the remaining 5 products are just add-ons like multivitamins or moisturizers or things like that. So having a rational prescription policy would actually make medicines more affordable. Industry needs to self-regulate on the cost of high-price medicines like anti-cancer or critical care products. Otherwise, the government will always be there watching, because those are very expensive medicines and always in the limelight. And the government to work on expand the list of medicines that are covered under the government schemes. So that's it. To summarize my last slide, that manufacturers in India must continue to play. Next slide, please. A pivotal role in ensuring the affordability and accessibility of medicines. what we suggest is, last slide, collaborate with regulatory bodies to ensure compliance, adopt efficient manufacturing practices, engage in research and development, and explore partnerships with the government and NGOs, especially for essential medicines. Thank you.
Thank you, Mr. Sunil Akawar, sir. To honor Mr. Sunil Akawar. Thank you, sir. Our next speaker is Sri Somashekar, VK Managing Trustee, Grahak Shakti, who will enlighten us on the topic, role of NGOs in creating awareness about affordability and availability of essential drugs. A small profile of him. Sri Somashekar VK is the founder, Managing Trustee, Grahak Shakti, also Chief Promoter and Patron of Coordinated Action of Consumer and Voluntary Organization of Karnataka, also Consortium of South India Consumer Organization. He is a triple graduate with Masters in Business Law from National Law School and few PG diplomas. Professionally, he was a corporate executive with 34 years of experience. He was also a honorary tree warden of the Forest Department, was in forefront to save Cubbon Park campaign and responsible for intervention in preventing cutting trees in the city. A big round of applause to him for this social cause. An accredited journalist and an associated editor of the monthly Spade as Spade, also contributed several columns in newspaper and magazines. I request sir to present.
Good evening, all of you. Respected Mr. Kanewale Saab, Mr. Dr. Amresh Tumbargi, Mr. Sanjay Kumar, Mr. Auditorium Saab. Well, I have two things to start with. Number one, I have seen all the presentations today going through. I think right away, Mr. Kanawale and Amresh Tumbargi should sign an MOU with us. We are ready. You called what is the role of NGOs. All of them are saying civil society participation, stakeholder contribution, NGOs should involve. What's holding up? We'll get up, sign the thing and participate and start working from tomorrow. That is the way it is. Anyway, just short introduction about the way that worked some time ago. In the year 2013, we held a national conference here in Vidhanasabha. One of the most distinguished and three of the ministers, education, doctors' education and consumer affairs, everybody participated. It is even today spoken of in the national consumer movement. It was outstanding. And who gave us the backbone? The Drug Control Department. It is Mr. Dr. Tumbargi who stood, doing all the governmental kind of permissions, and we conducted fabulous work. It's a memorable. Subsequently, 10 organizations in the country were invited by National Institute of Biological Studies for a 2-day workshop. Mr. Malikarjun and Mr. Venkatesh, your research and control, was also there with us. Pharmacy industry was with us. All of us took part in a 2-day conference, and that was about spurious and substandard drugs. how to conduct, how to collect samples. I mean, just going and collecting samples is as simple as that. But it was not so. It was an eye-opener. And each and every workshop we participated, it was mind-boggling. And we learned a lot of things out of it. So that was another involvement. And mind you, this WHO declared us as one of the best in terms of collection of samples throughout the country. Outstanding. And the department, thanks to the department, drug control department, is fabulous. We held and walked with them and did a fabulous thing. And that was those times. I'm so proud of our drug control department here that we have the third best lab in this state. And after this corona, what we call them just as corona warriors, one amongst the kind of thing. They're not warriors. I mean, if there is any term bigger than that, they are fabulous people who did beautiful work during that particular regime. How did this whole transformation happen? What was the secret behind that? And what kind of inherent capacities these people had? It came out when in the whole world, incidentally, I can say with little more authority, my brother and my sister-in-law are researchers running a lab, previously in Chicago, now in Arizona. Of course, my brother found out some new innovation and got patented, all that kind of thing. That's a different issue. They were, cautioning me, this India will have that. And they have started. They said, the way you people handled the thing, of course, you have become a citizen there, the way you people handled the pandemic and how you tackled this is something phenomenal. The whole world speaks about it. I'm so proud to be an Indian in that kind of way. So, what is this inherent capacity these people have got? And why not see? In fact, Mr. Sanjay Kumar, I would request you, this program should be a G20 program. This is a showcasing of our capacity to the G20 countries. And incidentally, I still walk with you. If you can really put across to the Union Commerce Minister and the Consumer Affairs Minister, Piyush Goyal, we will support you in all of this thing, because the entire, as he was mentioning, a small thing, we are present in all 31 districts of Karnataka. All 31 districts. And we have gone up to the taluk levels also. We can make participation. We are present in Kerala like that, Puducherry, 10 districts of Tamil Nadu and Andhra. Let me assure you that you will get maximum cooperation and participation from South India. Why not we do this kind of a thing? What a mind-boggling kind of knowledge that we got. That is why I was playing it a little safe. When Mr. Tumbargi, Dr. Tumbargi put his people around, said, where is your presentation, where is your presentation? I played a small trick, let me be honest, because I am from a corporate company. I worked in Tata's for 16 years and I was the CEO of a media entertainment company. This trick I have played it with my managing director. So why don't he wants a PPT at the same time presenting it in front of all you experts. What am I going to do in that? Just picked up some few things, and what I am going to speak is more on extempore rather than that. That's the secret. So, why I want to tell you about stories about this? There are two friends of mine, one family. During the corona pandemic, that person was extremely cautious, very cautious. That friend of mine, who's actually my shadow, used to walk with me, do everything for me in this. He was so cautious, mask, vaccination, everything. Unfortunately, we lost him in corona. His brother was a flamboyant, freakish. He brought that the thing and he lost him. His father was a little old, 85 years old. He suffered from this. That's the corona story. Plenty of stories. That time, his father got into the second effect. not the corona, the thing, second effect. They are my personal experience. One particular drug was not available. They had not, state government said, somewhere this brother heard him saying that it is controlled by Drug Control Department of Karnataka. So I had to rush to my friend. I said, what is this? Here is the gentleman, Kanapur, who told me, sir, no sir, we don't control that. Well, this is the thing, but we have to help the patient. Please do it. I'll give you a number, one Hegde number. Please contact him immediately. Let's save that patient. He is the controller. All that he could have said, we don't do it, simple as that. Why is he putting this personal thing at stake? Why is he going out of the way to save a patient? It was mind-boggling. Of course, the patient died of that, even in spite of the doctor being impressed upon him and then got him the medicine. Later on, that medicine, when it was replaced, he was no more. 2 people in the family. But look at these people. Look at how they work. So, there is plenty of synergies that can happen. Plenty of synergies that can make things work. Why are we waiting? Ever since I have been part of the drug control, whenever they call me, to be very honest with you, today I am actively involved in TRI. We are in the TRI Citizen Consumer Action Group, which is a big kind of thing. We are supposed to hold 6 consumer awareness programs in all over the place. And 6 districts I have chosen, already 5 finished, 5 more, another 6. I was supposed to be ours in Dharwad. And I am part of the appellate authority of Airtel and Vodafone. So it is very important that I should have been there in Bellary today. They are organizing a program where I should have been in 3 o'clock. They were frantically at me. I confused this date as 11th and 12th. I thought 12th. So I wanted to go there, took my car, went there. I thought I'll be here. And I find that frantically I'm supposed to be here on 11th. Yesterday night at 11 or 12 o'clock, irrespective of whatever it is, I canceled my other program. I thought I should be here because this department means a lot to me. It's very important. And the synergies that can work with us. The consumer, one of things don't work. We have to do lot of things together. We have to reach out to consumers. Where we serve in your program, the Ayushman Bharat. And that's what I said. Hitherto, whenever I spoke, it was easy for me. Burre Committee report, 1948, this is what they said in our principal sitting there, 3% of GDP is not there. I used to be thorough, like a zombie I can speak. Now I have to refresh my memory. What kind of developments are taking place in the ministry? What kind of changes are taking place? Like exactly what you said. That strength that was given. Oh, Bapre. It is changed the perception of this. You know how many families are thankful? How many families are grateful? And with a mild resistance, I should say this, with a mild resistance from doctors. Doctors don't want this kind of a reduction for whatever reasons. Okay, they are also human. So, they didn't want, and how it was managed, how it was, brought into force and it's working. And my brother also, another brother was recently there from the US. He wanted a medicine. He was prescribed something. He said, go to a shop there. It is a Janaushadhi shop. Buy it. I wanted his reaction. He went there and he said, is it a fake medicine? I said, why? He said, no, so cheap. I said, cheap means fake? Who said it is fake? That kind of, you only want a brand. You want highly colored, branded thing. That happens in US. Here everything is cheap, but effective and works well. Have this, I will give you a and then we made him buy that. So what I am trying to say is, a lot of reach out is required. A lot of advertising. Consumers are waiting for this. And we have got the best of brains. Honestly, let me tell you, we are the best of brains partnership of medicine. My colleague Bijan Mishra is there. He's doing a marvelous work as of international policy is concerned. Let's all get together. rights to wealth. And these things, like example, next slide please. The thing that goes on, see, this is also a human rights kind of an issue. So, where are we waiting from? Look at this. Access to essential medicine, these are all in terms of principle, the provision of healthcare, all that, it is tremendously changed. It is just a metamorphosis. And if this too did not happen, Mr. Sanjay Kumar, please convey this. If this too did not happen, along with whatever is happening around us, in terms of medicine, in terms of marvelous work that you people are doing, I'll tell you, there will be a civil war in India. Would have been. There would have been. We avoided a lot of things. We are sitting very pretty in the whole kind of gamut of this thing. How does it happen? And look at the change in the perception of this thing. I haven't come across, I'm 45 years, not the age, by the consumer activism that I have been doing. I've never come across anybody asking me to agitate against prices of medicine. Never. Nobody is making a decision. If at all, with all due this thing, our gentlemen, the manufacturers are also, there is a slight here and there this thing. Unfortunate. I mean, sometimes they get the thing of medicines kind of this thing. Next slide. So, what is it that ails us? What is it that we have as all our parameters, all our figures that are showing today? WHO actually, has become a kind of this thing. I have recently, our ex-controller was also in Delhi, looking after DRW. Some of the WHO officials whom I met, they are extreme praise of what's going on in India. They were very happy of things that are taking place. And today, let me tell the august audience, I don't know, this perhaps is our Prime Minister's forte or his side. He picks somebody from the right kind of place and puts them to work there. And that is what he has done in bringing Mr. Rajiv, Chief of Drug Control of India. He's a phenomenal person. Wait for me. 2-3 years he's going to be there. And he's going to do a lot of things. He started doing something. But there's plenty of things that's going to happen. So, NGOs, I'm a little hesitant. I came back, I think Mr. Tumbigi would have noticed, I made it as VCOs, a little coverage. Not that we are also highly perfect. NGOs have got a bad name. So, we are voluntary consumer organizers. So, we are a little better than that kind of thing because we still have some kind of credibility with the consumers. We are doing a lot of work. So therefore, if you look at the global kind of index, SDGs, with the kind of transformation that is taking place, with the thing, see, for example, Ayushman Bharat, along with the pricing, put together, the global index, once upon a time, we were also criticized. Next thing. I'll give you some graphs actually. The age, factors of what people used to say is malnutrition. And I know plenty of doctors who are part of the thing. They used to protest and they used to say our malnutrition and not only malnutrition, we don't have midwives to do delivery, and we lost a lot of mothers due to pregnancy because we are not capable. We don't get to hear them these days. Where did they come from? What statistics you found some suddenly? We don't know. See, all this transformation insert, there is a kind of activity that is taking place, and not only we are far ahead of the demographic dividend that we are bound to happen, we are also longevity at this point of time is taking a little longer. I've got that slide also. So, we are the kind of things that are taking place, the transformation that is happening phenomenally. Our age, this thing is also being pushed a little more, if not to the world standards of 72 years, 69, 70 years, where our kind of blessing comes up there. So therefore, we need to celebrate this. We need to work together. And this is something which health and wellness are something which we have been craving about. And multitudes of that. For example, the Swachh Bharat has contributed to some extent. The yoga for all has contributed to some extent. That becomes a wellness kind of a advanced thing. The medicines have contributed to something. Ayushman Bharat insurance, Arey Baba, today I am telling you, the poorer family whom we work with in the weaker sections also, in the rural areas, they tell us, ನಿಮಗೆ ಆರೋಗ್ಯ ಕೆಟ್ಟದ್ರೆ ಏನು ಮಾಡ್ತೀವಿ? ಇಲ್ಲ ಸರ್, ನಮಗೆ ಭಯ ಇಲ್ಲ ಸರ್. ಏನು ರೀ ಭಯ ಇಲ್ಲ? ದುಡ್ಡು ಮಾಡಿಟ್ಟಿರಿ? ಇಲ್ಲ ಸರ್, ದುಡ್ಡಿಲ್ಲ ಸರ್. ನಮಗೆ ಇವರು ಕೊಡ್ತಾರೆ ಸರ್, ನಮಗೆ ಇನ್ಶೂರೆನ್ಸ್ ಬರುತ್ತೆ ಅಂತ ಸರ್, ಅವ್ರು ನೋಡ್ಕೊತಾರೆ. This I mean ignorant actually, but they know something available that they don't have to worry about, that they don't have to sell the property, that they don't have to sell the biggest thing that is the Mangalyam or whatever. That kind of relief is there today in the society that is happening. So if that is happening, it's all because of you people. So if we can do, like I think you can do more. You can push it yourself, you can do more. And we will participate in it. We will change whatever has to be changed. Next slide, please. I think I will finish off fast. We can be the change that we want to be. Let us also see, for example, somebody said, you are now suddenly you become very positive, you become pro-government. I said, no, look, I am not pro-government, anti-government, always. I am looking for what people can get, our quality of life that can happen. If these are happening, prove me wrong, I'll be with you. I'll come with you. Hold this placard, sit and that can satisfy you. We have to be criticizing everything just for criticism's sake. I am not for it. See, for example, then they asked me, you mean to say the pricing done by, Tata MG has started online. The other people have started easy, pharma easy. What are you going to do about it? I said, wait. Each of that, we have got the power. It is settling down by itself. Just watch, I said. And I wanted to narrate a beautiful anecdote for you if you have not come across. Caveat is, I can only quote, testify that you should do it, verify that you do it. If there is something wrong, get back to us. Stop us from, carrying this campaign. But let me tell you, what is it? Dr. Senthil is from Tamil Nadu. He has worked in the industry for 20 years, corporate industry. He has come out for whatever reason. He has analyzed I'm giving you a synopsis. He has analyzed the quality of doctors. He says there are 3 types of doctors. One, very good, versatile, he can speak well, he can deliver everything. He is beautiful. But in terms of his real skill as a doctor, he is not to that standard. Then there is another doctor who is very good, who does everything silently, who cannot communicate to the patient, but is a very good doctor. So there are such categories of them. The third category, he says, are ethical doctors who have taken this profession so seriously that they are highly ethical, they are personalized. You cannot change them, they are personalized, they are one-to-one. So in one of your slides, somewhere I saw mentioning that there is need, I think Shastri also, need to be personalized. You need to be personalized. That is being lost is what we are trying to do, the artificial intelligence. I have come across an artificial intelligence introduced in a school where the teacher he started teaching in completely, the teacher is a dummy. The teacher is a robot and she teaches. And the students are just, you ask them any question, it's like a Google. It's like your the things which have come up. It can answer anything. But that personal kind of guru, shishya, this thing is not developed. And that is India, where we have that kind of a personal kind of a this. So, what happens in that artificial intelligence is you lack the kind of drive that you want from the doctor. So you don't go to a doctor for these kind of things. So what happens actually is the third kind of doctors. Now this Dr. Sindhu has collected the third doctor's names and kind of experience. He has collaborated about 3,000 to 5,000 doctors. Now he is applying to you free. He will give it to you free. He has got a WhatsApp number. He will share his WhatsApp number. Of course, that's in Tamil Nadu, in Chennai. So you have to talk to him probably in that. Or maybe somebody support him or whatever. But that is free. He will give it to you free 24/7. Every day there is a rush. Already 10,000 people have registered into that. You want a doctor. You want a personalized doctor. You want some kind of advice. If you happen to be a little more confident, if you share your illness, probably they will refer you to the best doctor in that profession and give you some more advice. So what am I trying to say? Action and get my equal and opposite. If somebody is doing this kind of thing, there is somebody else who is doing the other kind of thing and counterbalancing. I said this can happen. Now, for example, the call drop in the telecom industry. I have been working too much in the telecom industry, so call drop. Sorry. I was part of the campaign, CNN campaign. Prime Minister Modi ji, Ravi Shankar Prasad, both of them. They went hammer and tongs, they said, okay, try, do yourself, all that. Now tell me, who was talking about call drop? Don't occur. I provoke people. Come tell me where is the call. Why did it not occur? It is because the times have changed, the technologies have changed, the 5G, 6G technologies have come. It has overtaken that, overshadowed that. Now automatically, so things, forces will come. When you give an impetus to this, it elevates you to a different level. Things automatically change. So even here, these kind of things can definitely happen. Next slide. So, next and next, continue with that. So, what is all this happening? See, these are plenty of information available now. Information, there is no dearth of information. There is nothing new that you will find in any of the information I am giving, honestly. Because this is again pirated. Somebody has given me this information which I feel is authentic and I am sharing it. Some from the government portals, some from the thing, a little bit of research. But look at that, I mean, admirable actually. And fortunately, I hope Dr. Jagdish is not listening to me because he is part of the Federal Drug Agency, FDA. There are plenty of people who have told me that Indian drug system is much powerful than the FDA in the US. I will go to somewhere, I think. Next please. I counted that also. Federal Drug Agency. And we are much better than America. America, we call them. But our people have done marvelous. Give them something. They don't ask you anything. Recognize it. Give them the thing. And I tell you, you can work wonders with this kind of thing. And with this short kind of a thing, and one or two more slides, I think this is look at that thing. GDP is growing in the health sector. This is economics, this thing, recently, which was on. So, huge kind of a thing. Next, please. See, this is the current health figures per capita thing about India. This is also WHO statement. Our reasonable kind of a thing that can exist now. Next. So, in this, of course, I had been privileged in the year 2015 to have associated, because Anant Kumar is a different kind of a minister. Often used to placate me, force me, provoke me. Come on, tell me, what do you find in this? Well, yet we fought. I used to find some defect and all that. But the kind of phenomenal decision that he took, I said, hats off to him. It was beautiful. And now this has started working. It is transforming, it is metamorphosing into plenty of changes. Mr. Sanjay will be carrying some inputs from here also, and it will be reflected in the course of time. Because sky is the limit for creativity. If you are creative, it is been accepted. And that is why I said, after this, what? Where are you going to take us? Mr. Karapure, Dr. Amresh Tumbargi, you must tell us how we can associate. I assure you, throughout the state, South India, of course South India is not usual, throughout the state, tell me which part of the state you want us to be. We want your authorities to handhold us. We will walk with you, but annually, see, if I have that, fortunately, I would have looked for this thing that you are going to give me, if at all. That seed which you are growing, I remember I got it last year. And one more year. If I want this to be given as a forest, I want the frequency to come from you, that we come regularly. We come meet regularly and we discuss with you. It's an engagement of wonderful thing. I still have the best of contact with every one of you, except that some who don't prefer, I leave them to have their own kind of a thing. But otherwise, it is wonderful working with you all. It is beautiful to synergize with you, and I hope you take this positively to the next level. And Mr. Sanjay Kumar will go back, and hopefully we'll be asked to prepare for the G20 to showcase this kind of a development to the rest of the G20 countries before we relinquish office. Thank you very much. The two more missing.
Sir, thank you, sir, for your concern appreciation of the Drug Control Department. We are really happy. I request our Drug Controller, Additional Drug Controller, to honor Sri Somashekar VK, sir. We'll have the last speaker of today's technical session. Hope you are really learning something. Are you learning? It's interesting? Good. Last speaker. Okay? This is going to be quite informative. Okay? He is none other than Dr. Amresh Tumbargi, sir, Additional Drugs Controller and Member Secretary, Executive Committee, PMRU, Karnataka. I'll just give a gist of his achievements, or else I have to talk. If I start talking about him, I have to talk the whole evening. I'll just give a gist. Okay, Dr. Amresh Tumbargi, sir, completed his D.Pharm from HKE Society College of Pharmacy in Kalaburgi. Postgraduate and PhD from JSS College of Pharmacy, Mysore. Also holds a PG Diploma in Quality Assurance from JSS University, Mysore. I don't think any person who has completed so much of pharmacy education, right from D.Pharm to PhD in pharmacy, PG Diploma department. A big applause to him for this. Joined the department in the year 1993 and raised to the position of Additional Drugs Controller. He also served as in-charge Drugs Controller Karnataka. He has done a commendable job. Recipient of several state and national awards from government and NGO. First to his credit, the Sarvatama Seva State Award, the Pharma Ratan Award, the Best Drug Controller Officers Award, the Outstanding Service Award, etc. A big applause to him. You can hear it from Dr. Amrish sir. I request him to finish it by 5 minutes.
Karnataka government in turn adopted issue of product permission under non-proprietary medicine, so that when we issue non-proprietary medicines, people can make under their brand names, under any brand names. At the same time, Government of India introduced Janaushadhi scheme to make generic drugs, so that affordable drugs can be made to the public. And at the same time, Government of India has came out with another program called price monitoring resource unit, where it is a live linkage between state government and central government, where people awareness activities of the central government as well as state government making availability of drug, and consumer benefits, which what are the things have been made has to be made to public. So my topic is rule of generic drugs. You know that after pandemic there is an increase in the 15% R&D expenditures. If you want to make innovator molecule from the candidate drug discovery to candidate drug discovery, pre-clinic, that is animal studies, or clinical study, human studies, or to make a product up to the market, it is nowadays costing $2.3 billion. One innovator molecule cost you $2.3 billion means in India currency it will become 19,000 crores money. If we want to make that type of product, convert into generic, after patent losing, we will convert into this thing. So it requires this thing. The generic drugs definitions have got a lot of, country-wise it is differing. India we have patent proprietary, non-proprietary, and US they have got a generic. US they says that the US generic definition, I put it in this thing, and EME says that quality, efficacy of the product remains same only. API is also same. We have WHO definitions differently. So overall, when you see what is the benefit of generic drugs is, so it depends upon the country how the definition of generic has been derived. Whereas some country, in India, if you consider generic, we have got a 20 to 70% of margin, whereas in US it comes around 80% of the margins. So I feel, so if you wanted to cut off the health expenditures, we need to go for a generic drugs. If you see SNMC Standing National Medical Council report of 2012, so health expenditure goes 60%. Out of that, 40% goes to the medicines. If you see Competition Commission report This is one company which is manufacturing one drug. If it is making another drug and several brand names, several products are there, there are hidden charges in there. That are all those things can, in order to waive off, Government of India has brought out several guidelines to make it curb the activities. So in this case, Government of India has brought the NPPA for fixing of the prices. Overall, Government of India, it may be by silly fixing, exercising under para 19 or para 20 or schedule formulations, they are capping the drugs to make affordability of the drugs. Over and above, which are there covered under medical devices or which are not covered under this, depends upon the need of this thing. They also covered under TMR activities, where around 70% is the first seller it goes, and remaining is the carry forwarding activities. Overall, they made it as a Government of India has made so exercises NPPA DPCO powers under ceiling of prices as well as TMR. I feel government has done all its best efforts to make affordability of that. Only thing is we need with this platform, I will request all peoples to percolate how Government of India or Government of Karnataka has made affordability of medicines to in the healthcare activities, so that today's workshop will become a fruitful to everybody. Thank you. Thanks a lot. Jai Hind, Jai Karnataka.
So we are coming to the end of the session. The man behind today's program success is none other than our Dr. Amresh Tumiji sir. His vision in bringing the pharmacy fraternity on a common platform by creating this technical session is really commendable. A big round of applause to him. I request our drugs controller Shri Bhagavaji Kanapure sir and chief guest of today's function and all the other dignitaries to kindly join and honor Dr. Amresh Tumiji sir. Please sir. Sunil Chatwankar, please. I request all the dignitaries to stay back. One more. Our drugs controller, Shri Bhagavaji Kanapure sir. Our drugs controller, Shri Bhagavaji Kanapure sir, who has guided us and monitored the arrangements made, and the success of the program is seen today. He is always our strength, who encourages for a good cause. A big round of applause to him for making this program a grand success. I request the dignitaries to please honor Dr. Shri Bhagavaji Kanapure sir, drugs controller for the state of Karnataka. Umesh, please join me. Thank you, sir. We have come to the end of this technical session. Hengittu program? Technical session hengittu? Informative ಆಗಿತ್ತಾ? ಜೋರಾಗಿ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ. ಇನ್ಫಾರ್ಮೇಟಿವ್ ಇತ್ತಾ? ಈಗ ಎಷ್ಟು ಕಲ್ತಿದ್ದೀರಾ ಅಂತ ನೋಡೋಣ. ಒಂದು 2 ನಿಮಿಷ, ತುಂಬ ಹೊತ್ತು ತಗೊಳ್ಳಲ್ಲ, ಬೇಗ ಕಳಿಸ್ಬಿಡ್ತೀವಿ. 2 ನಿಮಿಷ ನೀವು ಏನೇನು ಕಲ್ತಿದ್ದೀರಾ ನೋಡೋಣ. ಅದಕ್ಕೆ ಒಂದು ಸ್ಮಾಲ್ ಕ್ವಿಜ್ ಪ್ರೋಗ್ರಾಮ್ ಮಾಡ್ತಿದ್ದಾರೆ ಇವರು ನಮ್ಮ ಸುನೀಲ್ ಚಿಪ್ಲಂಕರ್ ಅವರು ಪ್ರೈಸ್ ಕೊಡ್ತಾರೆ, ಗೆದ್ದವರಿಗೆ ಪ್ರೈಸ್ ಕೊಡ್ತಾರೆ. ಮತ್ತೆ ಯಾರು ತಗೋತೀರಾ ನೋಡೋಣ ಪ್ರೈಸು. ಅದಕ್ಕೆ ಮುಂಚೆ ಅವ್ರ ಬಗ್ಗೆ ಒಂದು ಸ್ವಲ್ಪ ಮಾಹಿತಿ ಕೊಡ್ತೀನಿ. He is the Vice President, Business Development Group Pharmaceuticals Limited. He is a very important person. ನಮ್ಮ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಕನ್ಸರ್ಟ್ ನಮ್ಮ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ನೋಡಿದ್ರೆ ಆರ್ಗನೈಸಿಂಗ್ ಎನಿ ಪ್ರೋಗ್ರಾಮ್ ಬಿಕಮ್ಸ್ ಈಸಿ ಬಿಕಾಸ್ ಟೆಕ್ನಿಕಲ್ ಸಪೋರ್ಟ್ ಅಂತೂ ಪಕ್ಕ ಕ್ಲಿಯರ್ ಆಗಿ ನಮಗೆ ಕೊಡ್ತಾರೆ ಅವರು. ಆ್ಯಂಡ್ ಈಸ್ ಆಲ್ವೇಸ್ ಈಸ್ ಕಾಂಟ್ರಿಬ್ಯೂಷನ್ ಇವತ್ತು ನೋಡಿದಿರಾ, ಅವ್ರ ಕಾಂಟ್ರಿಬ್ಯೂಷನ್ ಇವತ್ತು ಎಲ್ಲ ಟೆಕ್ನಿಕಲ್ ಸಪೋರ್ಟ್ ಅವರಿಂದನೇ ಆಗಿರೋದು, ಇನ್ಕ್ಲೂಡಿಂಗ್ ಸರ್ಟಿಫಿಕೇಟ್ ಎಲ್ಲ ಇಟ್ಕೊಂಡು. ಸೊ ಎ ಬಿಗ್ ರೌಂಡ್ ಆಫ್ ಅಪ್ಲಾಸ್ ಟು ದಿಸ್ ಮ್ಯಾನ್. I will leave it to Sunil for conducting the quiz. Thank you.
No. This is called mob quiz. Mob ಅಂದರೆ ಜನ ಎಲ್ಲ ಸೇರ್ಕೊಂಡಿರೋದು ತಾನೆ. ಸೊ ನೀವೆಲ್ಲ ಸೇರ್ಕೊಂಡಿದ್ದೀರಾ. ಇವಾಗ ನಾನು ಓಪನ್ ಆಗಿ ಕ್ವಶನ್ ಕೇಳೋದು ಹೇಗಂದರೆ, ಅವರೇ ಪಿಕ್ ಮಾಡ್ತಾರೆ ಕ್ವಶನು, ನಾನೇನು ರಿಗ್ಗಿಂಗ್ ಮಾಡಲ್ಲ. ಅವರೇ ಕ್ವಶನ್ ಪಿಕ್ ಮಾಡ್ತಾರೆ. ಆನ್ಸರ್ ಯಾರು ಕೊಡ್ತಾರೋ ಅವ್ರಿಗೆ ನಾವು ಪ್ರೈಸ್ ಕೊಟ್ಬಿಡ್ತೀವಿ. ಓಕೆ, ಸೊ ಸ್ಪಾಟ್ ಪ್ರೈಸ್. ಅಲ್ಲ, ಕ್ಯಾಶ್ ಅಂದಿದ ತಕ್ಷಣ ಎಷ್ಟು ಖುಷಿ ಆಯ್ತು ನೋಡಿ ಜನರಿಗೆ, ಅದಕ್ಕೆ ನಾನು ಹೇಳಿರೋದು. Amrish Tumge sir is, Dr. Amrish Tumge sir is monitoring the online submissions also. Okay, so online ಅವ್ರಿಗೆ ಹೆಂಗೆ ಅಂದೋಡಿ ಒಂದು ಪ್ರೈಸ್ ಹೋಗ್ಬಿಡ್ತು, ಅದು ಕವರಲ್ಲಿದೆ ಅಷ್ಟೇ ಇರೋದು. ಡಾಕ್ಟರ್ ಉಮೇಶ್ ಸರ್ ಅವರು ಕೈ ಹಾಕೇ ಬಿಟ್ರು ಅಲ್ಲಿಗೆ. ಓಕೆ, ವಿಲ್ ಸ್ಟಾರ್ಟ್ ವಿತ್
ಒಂದು ಸ್ಮಾಲ್ ಥಿಂಗ್. ಎಡಿಸಿಗಳು ದಯಮಾಡಿ ಆನ್ಸರ್ ಹೇಳಕ್ ಹೋಗ್ಬೇಡಿ. ದಿಸ್ ಇಸ್ ಅದು ಈಗೆಲ್ಲ ಪ್ರೈಸ್ ಎಲ್ಲ ಕೆಮಿಸ್ಟ್ರಿ ಹೋಗ್ಬೇಕಾಗಿರೋದು. ಎಡಿಸಿಗೆಲ್ಲ ಏನಾದ್ರು ಸಪೋರ್ಟ್ ಮಾಡಬೇಕು, ಕೆಮಿಸ್ಟ್ರಿ ಸಪೋರ್ಟ್ ಮಾಡಿಬೇಡಿ ಅಷ್ಟೇ. ಹಲೋ,
ಎಲ್ಲರೂ ನಿಮ್ಮ ಶೈಲಿಯಲ್ಲಿ ನಿಮ್ಮ ಕನ್ನಡದಲ್ಲೇ ಮಾತಾಡಬೇಕು, ನಾರ್ತ್ ಕನ್ನಡ.
Question number 7. International Yoga Day is celebrated on dash dash. Why are you telling them? Okay, please come.
Podcast, what price? June ಅಲ್ಲ, July.
ಕೊಡಿ ಸರ್.
The question is, sildenafil citrate, that is Viagra, is a popular drug for sexual wellness. Initially, for which disease was the clinical development done?
I want more specific. Tachycardia. Okay, then anybody else? ಹೇಳಿ ಟ್ಯಾಕಿಕಾರ್ಡಿಯಾ ಹೇಳಿದ್ರಿ, ಆಮೇಲೆ ಇನ್ನು ಕಾರ್ಡಿಯಾಕ್ ಕರೆಕ್ಟೇ, ಇನ್ನೂ ಸ್ವಲ್ಪ ಡೀಟೇಲ್ ಆಗಿ ಹೇಳಿ. ಅದು ಬಿಟ್ಬಿಡಿ, ಕಾರ್ಡಿಯಾಕಲ್ಲೇ ಹೇಳಿ ಏನಂತ. ಬ್ಲಡ್ ಸರ್ಕ್ಯುಲೇಷನ್ ಆಯ್ತು. ಇನ್ನು ಏನಾದರೂ ಹೇಳಿ, ಇನ್ನು ಕಾರ್ಡಿಯಾಕ್ ಡಿಸೀಸ್ ಯಾವ್ದಿರುತ್ತೆ ಹೇಳಿ. ಥಿಂಕ್. ಕಾರ್ಡಿಯಾಕ್ ಡಿಸೀಸು. MI, very near. I will give it to you, Bunny. Actually, it was for hypertension and angina. MI is very near, so we will give it to him. Okay, so this is the prize for him, sir. Inko de dijiye. Please give a round of applause. Illa main Bunny. ಚೆನ್ನಾಗಿದೆಯಾ ಸರ್? ನಗ್ತಾ ಇದ್ದೀರಾ? Yes, congratulations. Thank you. Somebody is joking on my on it. Oh, it's not a what is that? Hello? Hello? Hello?
Modern lifestyle, one of the S is deprived, dash, dash, dash. There is S, dash, dash, 5 letters word, deprivation. Guess the 5-letter word starting from S.
Stress is 6 letters. S-T-I. Yes, sleep piano. Must, bane. Sleep. Hello,
You will give birth to.
We'll give both. Congratulations. Very good technique. Very good. Very good technique. These are all smart guys, huh? Very nice. You ನಿಮ್ಮ ಹೆಸರು ಹೇಳ್ಬೇಕು. ನಿಮ್ಮ ಹೆಸರು ಹೇಳ್ಬೇಕು. ಅವಾಗ ಭಿನ್ನಾಗಿರೋರು ಯಾರು? ಹೆಸರು ಹೇಳ್ಬೇಕು. ಅವಾಗ ಭಿನ್ನಾಗಿರೋರು ವಯಾಗ್ರ ಹೆಸರು. ಗೌಸ್ ಮೆಡಿಕಲ್ ಎಲ್ಲಿ? ಡಿಜೆ ಇನ್ನೊಬ್ರು ಯಾರು ಗೆದ್ದಿದ್ದು? ಮೇಡಮ್ ಆಯ್ತು, ಓಕೆ. ಉಮೇಶ್ ಸರ್, ಇವರ್ ಐನ್ ದ ಪ್ರೈಸ್. ಬನ್ನಿ.
Name the act in USA that has put control on pharmaceutical marketing expenses to doctor. Name the act in USA that has put control on pharmaceutical marketing expenses to doctor.
ಡಾಕ್ಟರ್ಗಳಿಗೆ ನಾವು ಫಾರ್ಮಾ ಮಾರ್ಕೆಟಿಂಗ್ ಪೀಪಲ್ ಜಾಸ್ತಿ ಏನು ಕೊಡಬಾರ್ದು ಅಂತ ಒಂದೇನೋ ಮಾಡಿದ್ದಾರೆ. ಏನು ಅದೇ ಅದಕ್ಕೇನು ಇದು ಎಕ್ಸಾಕ್ಟ್ ಆ ಗಿಫ್ಟ್ಸ್ ಬಂದಿರೋದು ಡಾಕ್ಟರ್ಗಳು ಏನು ಮಾಡಬೇಕು? USA, ಇಂಡಿಯಾದಲ್ಲ, USA. ಸ್ಪೀಕರ್ ಫೀಸ್ ಕೊಡ್ತಾರೆ, ಡಾಕ್ಟರ್ಗಳಿಗೆ ಏನೇನೋ ಕೊಡ್ತಾರೆ. ಅವ್ರು ಏನು ಮಾಡಬೇಕು? ಡಾಕ್ಟರ್ಗಳು ದೇ ಆರ್ ಸಪೋಸ್ ಟು ಪುಟ್ ಇಟ್ ಇನ್ ಟು ಅ ವೆಬ್ಸೈಟ್. US ಗೌರ್ಮೆಂಟ್ದು ಒಂದು ವೆಬ್ಸೈಟ್ ಇದೆ, ಅದ್ರಲ್ಲಿ ದೇ ಹ್ಯಾವ್ ಟು ಪುಟ್ ನನಗೆ ಸ್ಪೀಕರ್ ಫೀಸ್ ಬಂತು, ಇದು ಬಂತು ಅಂತ ಅವ್ರು ಹಾಕಬೇಕು. ಸೊ ವಾಟ್ ಇಸ್ ದಟ್ ಕಾಲ್ಡ್? ನೋ, ವಾಟ್ ಇಸ್ ದಟ್ ಆಕ್ಟ್? No, that act, that particular act, what is it called? Surya, ಅಷ್ಟೇ ಹೇಳ್ತೀನಿ. ಸೂರ್ಯ, ಸನ್, ಯಾರಿಗೂ ಗೊತ್ತಿಲ್ವಾ? DDC, ADC, ಸನ್ಶೈನ್ ಫಿಸಿಷಿಯನ್ ಪೇಮೆಂಟ್ಸ್ ಆಕ್ಟ್ ಅಂತ. ಏನು ಹೇಳಿ? ಸನ್ಶೈನ್ ಫಿಸಿಷಿಯನ್ಸ್ ಪೇಮೆಂಟ್ ಆಕ್ಟ್. ಸೊ ಇನ್ USA ನನಗದು ಅಲ್ವಾ ಸರ್? ನನಗೆ ಅದು ಅಲ್ಲ, ನಾನು ಹತ್ರ
Easy question. Question is, which country other than India took inspiration from Hathi Commission and regulated the medicine prices for affordability?
Some other country took inspiration from Hathi Commission report and then they regulated. Afterwards we followed. Brazil, UK. Okay, I'll give one hint. ಇಲ್ಲ, ಹಿಂಟ್ ಕೊಡ್ತೀನಿ. ಎಲ್ಲ ಹೇಳಾಯ್ತು, ಕಂಟ್ರಿ ಹೇಳ್ರಿ, ನೀವು ಕಾಂಟಿನೆಂಟ್ ಹೇಳ್ತೀರಲ್ಲ. ನೈಜೀರಿಯಾ ಮೇ ಅರೆ छोड़ो यार. I will give one hint. Neighboring country. Who said Bangladesh? Very good. Sir, good. Yes, Bangladesh. sir, Suresh sir. Oh, sportsman. Charming personality.
These days, there are many cases of cardiac arrest. These days, many popular figures have fallen to the cardiac arrest. What is the main reason for the cardiac arrest that differentiates it from the heart attack? Good question. What is the main reason for the cardiac arrest that differentiates it from the heart attack?
ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ಗೂ ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್ಗೂ ಏನು ವ್ಯತ್ಯಾಸ? ಈಗ ನಮಗೆ ಗೊತ್ತು ಪುನೀತ್ ರಾಜ್ಕುಮಾರ್ ಅವರೆಲ್ಲ ದೇ ಆಲ್ ಸಕಮ್ ಟು ಇದು ನಿನ್ನೆ ಮೊನ್ನೆ ಒನ್ ಲೇಡಿ ಸ್ಪಂದನ ಶಿ ಆಲ್ಸೋ ಕೊಲ್ಯಾಪ್ಸ್ ಡ್ಯೂ ಟು ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್. ಸೊ ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್ಗೂ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ಗೂ ಏನು ವ್ಯತ್ಯಾಸ? ವಾಟ್ ಇಸ್ ದ ಡಿಫರೆನ್ಸ್? ಡಿಫ್ರೆನ್ಸ್ ಹೇಳಿ. ಆಯ್ತು, ನಾನೊಂದು ಹಿಂಟ್ ಕೊಡ್ಲಾ? ಯಾವುದರಲ್ಲಿ ಹಾರ್ಟ್ ಮಸಲ್ ಸಾಯತ್ತೆ, ಪೋರ್ಷನ್ ಆಫ್ ದಿ ಹಾರ್ಟ್ ಮಸಲ್ ವಿಲ್ ಡೈ ಇನ್ ಒನ್ ಆಫ್ ದೀಸ್ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್. ದೆನ್ ವಾಟ್ ಡು ಯು ಥಿಂಕ್ ಹ್ಯಾಪನ್ಸ್ ಇನ್ ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್? Yeah, that is correct. Even in heart attack it will stop. But why? Yaru? Electrical conductivity. Okay. Manjula madam started first, so she will get the prize. Arrhythmia, abnormal arrhythmia. ನೀವೇ ಕೊಡ್ಬೇಕು. ಸ್ವಲ್ಪ ಚಪ್ಪಾಳೆ. She has got good electricity in her. So after bioelectricity, Ramesh sir, please do the honors of asking the question.
Is the world's costliest drug. Vonasomanogen abbreviation is the world's costliest drug. It is an injectable used in infants less than 2 years for a rare disease disorder. Please mention which company manufactures this drug.
Correct. Krishna bola.
The Drug Price Competition and Patent Term Restoration Act helped create robust generic drug market in USA bracketed to improve affordability of medicines. What is the popular name of this act? Act?
Generic products
could able to generate prescription of 8%. After 10 years, they raised it to 13%. Writing generic prescription, even in US also, I am aware that this is a live listing. US also there is an issue in that. Everywhere there is a brand name and patent and everything. All these things are manageable and all marketing activities also there in all countries. I as you explained, Act is in 1984.
Please give a big hand.
Both are parliamentarians. There, the parliamentarians themselves introduced the acts. They also got a powers to introduce the act in the parliament. Can you give WHO definition of health?
WHO definition of health.
No. I repeat once again. Can you give WHO definition of health? Health definition given by WHO. That's what is the question. Can you give WHO definition of health?
You ಓದಿದ್ರಿ ಇವತ್ತು ಅವ್ರ ಸ್ಪೀಚಲ್ಲಿ ಹೇಳಿದ್ವಾ ಅಜಯ್ the keywords, I will give you the prize. Are super, give it to madam. Yes, physical, bunny, physical, mental and social well-being. ಏನಾಯ್ತು?
State of complete physical, mental, social well-being, or not only in the absence of disease or illness.
Prizes are.
Hello. Which is the most widely used legal psychoactive chemical in the world? Which is the most widely used legal Which is the most widely used legal psychoactive chemical in the world? Chemical.
Okay, ನೀವೆಲ್ಲ pharmaceutical ಆಗಿ thinking ಮಾಡ್ತಾ ಇದ್ದೀರಾ, ಹಂಗೆ think ಮಾಡಿ, but don't think it is a narcotic. Beautiful, Ajay.
Sunil, Dr. Sunil Chiplankar, a big round of applause to him. Excellent. You brought on the stress. Okay, getting to the presentation. Shall we continue for some more technical sessions? Okay, volunteers, please. ನಿಮ್ಮ learning experience ನ ಯಾರಾದರೂ ಒಬ್ಬರು share ಮಾಡ್ಕೊಳ್ಳೋಕೆ ಆಗುತ್ತಾ? ಯಾರಾದರೂ ನನ್ನ ಹೆಸರು ಗೋವಿಂದರಾಜ್ ಅಂತ. ಇವತ್ತಿನ
ನಡೀತು. ಹಿಂದೆ ಈ ತರ ಹಲವಾರು ಸೆಷನ್ಗಳಲ್ಲಿ ನಾನು ಭಾಗವಹಿಸಿದ್ದೆ. ಲಾಸ್ಟ್ ಟೈಮು
Affordability, ಅದ್ರ ಬಗ್ಗೆ ನಮ್ಮ Thank you, sir. Thank you. We are coming to the end of the session. Before that, with the program success, thank you,
Thank you.